that on the left, patients are treated with risankizumab, and you see a nice reduction in fecal calprotectin, and then they're re-randomized to maintain on RIS or to go on to placebo. And you can see that the calprotectins flatline, and that's because we're dealing with drugs with long half-lives. And what happens is that when we do network meta-analysis on this, these drugs don't come out particularly well because the induction was so good that they've kept the patients well for a long time. When you look at UPA with a half-life of hours, as soon as you come off the drug, you start becoming unwell, calprotectins go up. So in network meta-analysis, they look great. So what I'm trying to say is that these aren't the complete answers. So really, you want a head-to-head study, and we've got two really good head-to-head studies in Crohn's. The first is Seaview. This was published some time ago. Adalimumab versus ustekinumab. It was pretty straightforward. 400 patients with kind of standard active Crohn's disease, and they were double-blind, which is important, and you could have adalimumab versus usti, but importantly, you could not escalate your adalimumab. So you couldn't go up to weekly dosing as we're used to, and they all had to stop immunomodulators. So we know that anti-TNF seem to work better with combination therapy of azathioprine and methotrexate, and that had to be stopped. So it's a little bit like adalimumab was fighting with one hand tied behind its back. And despite that, when you look at it, there is really no difference. It failed to meet its primary endpoint of improved clinical remission at the end of a year. And when you looked, whichever way you cut the data, you saw a small numerical benefit of ustekinumab versus every other week adalimumab, but nothing else. So we've got a second study. This is a little bit more complex. This was the risankizumab versus ustekinumab study, the sequence study. And this took something that I think is very familiar to many people here. So the patients had all had an anti-TNF, and they were allowed to have more than one anti-TNF, but nothing else. And these patients were randomized one-to-one to either receive risankizumab versus ustekinumab. So it's really about saying, what's your next drug to use after an anti-TNF? And this was the design, and crucially, this was open label. So the patients knew what they were getting, and that's important to know. Because we recruited into this study, and you had patients who were being told that you could either have standard of care or you could get this new amazing new drug, and the ones who were on the new drug knew it. And so when you look at who made it out to week 52, more people made it to week 52 on RIS than ustekinumab, because people kind of knew that they weren't on perhaps the latest drug. Having said all that, their primary endpoint was a little complex: non-inferiority at 24 weeks and superiority with endoscopic remission at a year. These were the entry criteria, or sorry, the primary endpoints. And this was the inclusion and exclusion. You could have had more than one anti-TNF, but they had to be anti-TNF, so you couldn't have had Vedo. And this was the data, and it really was quite impressive. So it met non-inferiority, so it was not inferior to ustekinumab, and when they actually analyzed all the data together, they showed that it was in fact superior at clinical remission, both at week 24 and at week 48. And then what's really the hard endpoint was the endoscopic endpoint at week 48, and almost twice as many patients were in endoscopic remission at a year than was seen in ustekinumab. So when you're thinking to yourself, what am I going to use as a second-line therapy, I think this is quite powerful, and we have switched nearly all our second-line patients. We're not switching established patients in remission, but when we're thinking about what to use as a second-line agent, this is pretty powerful data. It had particular, I haven't shown you here, but it's got particular efficacy in ileal disease, where they were able to show, they looked at ileal CES-CD scores and able to show really impressive reductions with the use of RIS, which we haven't really seen. Ileal disease is particularly difficult to treat. Most of our trials are biased towards colonic disease. And it met all the other endpoints. So quickly, I'm going to controversially say, is it the drug or is it how you give it? And for this, I'm going to use one study. So we know that over time, we are giving drugs faster and faster, and that makes sense. In 2000, patients would have been had a diagnosis for a long time before they were being given infliximab, and obviously that's changing over time. The profile study, which was published at both ECHO and EDW and is now out in Lancet Gastro Hep, was actually designed to look at a biomarker. You may have heard of this before, and some of you may never have heard of it. This biomarker had been shown in a couple of studies and cohorts to seem to differentiate between patients who were going to have an aggressive disease course versus those who were going to have a benign disease course. It's the kind of holy grail. Who can you leave alone? Who do you need to treat aggressively? So they designed a head-to-head study with about 380 patients to either top down or step up. And they had equal numbers of the high versus the low risk groups in both. And the idea that they were going to show that the high risk groups would do better on top down and the low risk groups could go along on step up. But it's not what happened. When they looked at the end data, the important point before I show you this was that this was all about newly diagnosed patients. And the median time between diagnosis to starting therapy, they got down to 14 days in the NHS, in a state-based system in the UK. And that's because we designed clinics to try and pick these patients up as quickly as possible and get them onto treatment. And when we did that, we saw remission rates in the overall cohort group, steroid-free, surgery-free remission of 80% in those patients with top-up and versus step-down. Unfortunately, when they compared the high, the low, there was no difference at all. So this was a negative study, and yet it's been widely cited because it shows aggressive early treatment gets patients better. And there are some very hard endpoints to this. When you look at adverse events, it happens more in the step up than the top down. And most of that is driven by Crohn's flare. But the concern was always that we were going to be over-treating a cohort of patients. But that's not what we saw. And the only patients that were excluded from this study were those with undetectable CRP and who had just a very mild kind of CES-CD of less than 3. So those patients put to one side, you don't need to give them aggressive top-down therapy, but almost everyone else benefited from hitting them hard with infliximab in this case and an immunomodulator. And when you look at who needed surgery, this is just in 1 year. 10 patients in the kind of standard step up. And these patients were pretty aggressively, they went on to steroid, then azathioprine, then infliximab quite quickly, but 10 patients required surgery within a year, and the only one in the top down was for a gallstone ileus, not related to either drug or to the disease. So it's really impressive data. So what about biomarkers? Perhaps that's the answer. Well, we've had several studies that are using biomarkers, etrolizumab, which unfortunately didn't show benefit in phase 3, and then 2 that are using them now. There's some very interesting data coming from Oxford and Amsterdam looking at DNA methylation, and that potentially will show a signature. They were able to show which patients were going to do well on ADA, Vedo, and ustekinumab, and they've got enough money, £10 million from the EU, to do a huge study with 400 patients trying to show that this methylation signature would be able to predict who's going to do well. That's our sort of holy grail, that we can take a blood sample and know who will do well on which drug. So I'm going to finish on some practical guides. These are very much my own thoughts. So I thought if I had an ileocolonic young patient, no other concerns, we'd probably, based on profile, use an anti-TNF, but actually I'm pretty open to using ustekinumab or an anti-IL-23 as well. And as a second line, I'll probably be using an IL-23 based on the sequence data. If it's colonic, it's a bit different, and we think a little bit differently, and I'd probably still use infliximab rather than adalimumab and or Vedo, and then I think about UPA because the data there is very strong, in particular with colonic disease. Perianal, it's infliximab, and you're going to try and get everything you can out of infliximab. If they've been on it for years, I might even consider then as second line using a second anti-TNF or even a third, but UPA is our sort of go-to for perianal disease as a second line. Crohn's, older patients, comorbid, we're thinking about Vedo or the IL-23s and the 12-23s as well, and then anti-TNF probably only as a second line. And then ANC-SPOND and atopic dermatitis, you can use either anti-TNFs or the JAKs, and in this case that's UPA. Again, just always think about family planning in young patients, and obviously psoriasis and psoriatic arthropathy, you're going to try as hard as you can to keep using the IL-12s and 23s. Never forget your surgeon. So in all of this positioning, I haven't mentioned surgery once. If you've got limited ileal disease, and you fail one agent, it's 5 centimeters, it's a tight stricture, I think a surgery is a perfectly reasonable thing. Again, get ahead of the game and make sure they're on maintenance therapy afterwards. So, set the goals of treatment with your patient. Use rapid, effective therapy. Might be more important than which drug you use. Think of the whole patient together and set targets, and don't be afraid to switch them. And finally, never forget your surgeon. And with that, thank you very much.
I hope we'll take the questions at the end.
We will take questions at the end. Thank you for this outstanding presentation. So let's continue with our next speaker. Before our next speaker, I have the chance to introduce myself to you all. I'm Marios Katsaros, I'm a gastroenterologist from Thessaloniki, Greece. I'm truly honored to be here today at this prestigious congress. A heartfelt thank you to the Saudi Gastroenterology Association for this honorary invitation, and we are really excited that we have here with us Dr. Hiba Al-Farhan. Dr. Hiba Al-Farhan is specialized in diagnostic and therapeutic upper gastrointestinal endoscopy, inflammatory bowel disease, in gastroesophageal reflux disease, in esophageal pH capsule monitor, in peptic ulcer disease and Helicobacter pylori infections, in irritable bowel syndrome, in liver pancreatic diseases, in celiac disease, in abdominal pain cases of any kind of bleeding of the gastrointestinal tract, as well as his therapeutic endoscopies, interventional endoscopies. He deals with insertion and removal of gastric balloons and weight reduction. Dr. Hiba, we are looking forward for your presentation.
I guess we're dealing with some technical problem. No, I cannot. I need it here. Oh, it's there. So good afternoon, ladies and gentlemen, and thank you, Marios, for this intensive introduction. And at the beginning, please allow me to say thank you very much for the organizing committee. Thank you for Dr. Majid, Dr. Uthman, Dr. Nahla, Dr. Mahmoud Mousli, and Dr. Turki for giving me such a wonderful opportunity to participate. And I wish you guys many more success, because I can tell that this IBD masterclass is growing bigger and bigger and tracking the IBD figures all over the Middle East. So the topic that I was assigned for was the monitoring strategies in IBD. Here are my disclosures. It's hanged. The screen is not working. Excuse me. This one? Yeah. Okay. So during this upcoming 20 minutes, I will give you an overview about the updated goals in IBD management and the current way to personalize therapy. And then I'll go through the available control parameters and tool for the diagnosis and monitoring inflammatory bowel disease. And then I will focus further on the use of imaging in assessing the transmural healing in IBD. And at the end, I'll wrap up my presentations, giving you a clue about the future parameters, or I would say the promising parameters that can be used in IBD management. I guess we have. So regarding the updated goals in the management of inflammatory bowel disease and the way of personalized treatments for our patients, it's quite challenging up until now. And we heard from Gareth earlier in his excellent talk and excellent lecture that we need to identify the extraintestinal manifestations, we need to identify the disease severity and disease activity in order to select our ideal treatment for the patients. However, the question is, are we really have an ideal way to manage our IBD patients? Up until now, I guess the majority of us agree that these things are not available so far. So that's why we're targeting to have clarifications for the disease type and disease severity, and after that, keeping the patients in remission, like symptomatic, and we include the biochemical parameters. For Crohn's disease, for sure, we need the patients without any abdominal pain and without elements of diarrhea, and we need the absence of diarrhea and bleeding perirectum in case of ulcerative colitis. When we reach this point, we would like to keep the patients in a steroid-free remission and to maintain this symptomatic and biochemical remission. Also, we have to consider the other stuff, which is the extraintestinal manifestations, such as the pain, fatigability, mental, and sexual dysfunction. So it's not only the extraintestinal manifestations, however, we have to take the patient as a holistic whole in the management and in the way of identifying the extraintestinal manifestations and the luminal disease. We wish and we target to change the nature of the disease and the IBD history to avoid hospitalizations, complications development, and hospital admission. And the clue is, are we really reaching this point? For sure, everybody agrees that we did not reach this point up until now. However, monitoring the patients and following some certain parameters in regular basis can keep the patients in remission so far. So in order to monitor the patient, for sure, most of the randomized controlled trials and prospective trials were confirming the primary endpoint as clinical parameter, looking at the clinical parameters. And then the laboratory parameters can be very helpful in our patients. Also the endoscopic, which is the gold standard parameters that we should follow the patient on a regular basis to identify the disease activity. And now we have the informal transmural healing. This is another target that we're looking forward for using the radiological images. Up until now, even the updated clinical trials, even with the new medications that are available, and from what Dr. Parks told us earlier, the primary endpoint was symptomatic healing and the symptomatic remission. However, do we think that the symptomatic remission is our target, or would it be our future target? The answer for sure, no, because like 1 decade back, there was a good prospective trials. They included a good number of patients who were in remissions. And those patients were symptomatic remissions without any problem. However, when they scoped that patient, they found only 1/3 of these cohorts were in deep remission, symptomatic, histologic, and endoscopic. However, the rest, it was either they were having a disease activity in the endoscopy or by histopathological diagnosis. So what shall we do in order to change the nature of our disease activity is to control the inflammation. How can we control the inflammation? They added the other parameters, which is the laboratory parameters. So regarding the laboratory parameters, we have a really big list and big panels of laboratory parameters that we can use. However, all of us, we're focusing on the the main two, which are the CRP and the fecal calprotectin. Dr. Mahmoud, he's a person of the organizing committee, and he's an IBD specialist. In 2015, he had a wonderful systematic review, and he included around 19 studies with a cohort number of around 2,500 patients. And he found that the sensitivity of the CRP in identifying the disease inflammation was less. However, the specificity was okay. And the opposite was applicable in the fecal calprotectin, in which the sensitivity was higher in comparison to the specificity. So that's why, in order to reduce this gap and to avoid having a patients who are landing on the gray zone between the active and the inactive, having the combination between the two biochemical markers can be helpful. And when it comes to the laboratory parameters, for sure, we have to go through the CALM trials. It's the first prospective trials that was looking for the tight control using the clinical parameters with the symptoms, using the adalimumab medications, and in a comparison to the patient who were asymptomatic. And they found even during the follow-up by week 11 to 12, by week 35 to 23 to 24, and week 35 to 36, the fecal calprotectin and the biochemical markers were the main landmark that can help you and control the disease. And for sure, after completing 48 weeks, that the symptoms management alone, it wasn't that sufficient. So we need the biochemical and the laboratory together in order to have a better mucosal healing and better outcome for the patients. And then in the univariate analysis of the same study, we got to know that in order to have a deep remission, we need to have the combinations between the symptomatic and the biochemical parameters in which to keep the patient in more than 8 weeks to be steroid-free. And that has been approved already and included in 2023 guidelines, in which the AGA guidelines also gave us the same recommendations even if the patient is asymptomatic. And this is part of our regular monitoring for our IBD patients. Third parameters that we are always relying on are the endoscopy, and mainly the ileocolonoscopy and the flexible sigmoidoscopy. It's a gold standard for sure in identifying our IBD patients and monitoring our disease activity. It can evaluate the mucosa, it can evaluate the disease activity, we can see the ulcerations, the bleeding. Also, we can identify the complications, especially in the case of Crohn's disease, such as strictures. And it's part of the screening. So if you have a patient with ulcerative colitis and you need to screen the patients, also you can use it for a colorectal cancer surveillance. So no one can argue that this is the gold standard parameter up until now. However, would the patients like to go through this? For sure, no, because we cannot just keep monitoring the patient, ask the patients to take preparations, and even with experts, gastroenterologists, sometimes complications such as perforation may develop. But again, the mucosal healing is a target for us. So that's why we need a good scoring after doing the endoscopy for our patients. And we have a good number of endoscopic scoring that we can use. And the most common is the simple endoscopic score for Crohn's disease and the Mayo score for sure for ulcerative colitis. And they found in this meta-analysis out of 17 studies and with a total number of 2,608 patients that there was a difference between the Mayo score of 0 and Mayo score of 1. Mayo score of 0 can guarantee you that 52% reductions in the clinical relapse versus Mayo score 1. Despite in the clinical trials, the target was always looking for Mayo score 0 to 1. And also, the elements of relapses and the disease relapse on those patients, if he is a case of Mayo score 1, can go to up to 29%, and this can drop to 14%. If the patient is having a Mayo score of 0. Histological healing for sure will be helpful because it will reduce the risk of clinical relapses by 63%. I think up until now, the targets are clear and the parameters for following up the patient is very clear for us. However, what about transmural healing? Because we know that the colon has a multiple layering. So can we go beyond the mucosal level to know if the patient is in deep remissions or no, or the patient is responding or no? So the first approved radiological images that can be used for our IBD patients, we know that we have the MRE, we have the CT, and we have the CT colonography. And I guess the majority are requesting the MR enterography. And in this prospective trials, they found that if the patient using the MRE and after the confirmation that the patient is having transmural healing, when they compare it to the endoscopy, they found a better long-term outcome looking at the surgical interventions, less hospitalizations, and the patient doesn't need change in medication or escalation of the treatment. However, will you do this? And how long is the waiting list in your center? And will the radiologist accept that you keep repeating the MRE for your patients? What about looking at the other tool that is available, and it's a handy, and you can have it in your clinic, which is the intestinal ultrasound? Dr. Hamad is laughing. So intestinal ultrasounds can give you a transmural healing, can give you a good clue about what's going on beyond the level of the mucosa. So in this study, when they included around 150 patients of Crohn's disease, they were following them up using the endoscopy and using the intestinal ultrasound. They found that the patient who received the transmural healing, they were in steroid-free clinical remission for beyond the 1 year. And also they found that the clinical relapse rate was way lower than the patients who were having just only mucosal healing or endoscopic healing. And again, despite that it's an informal parameters that the transmural healing and informal target with the STRIDE-2 trials, we're glad to see that in STRIDE-2 trials that part of the cross-sectional images is the intestinal ultrasounds, in addition to the CT and MR enterography. And it can assess the degree of the inflammation, and also it can give you a complete transmural images for your IBD patients. We follow a certain parameters using the intestinal ultrasound that give you a clue about the inflammation, that can give you a clue about what's going on, and it can help you in diagnosing and monitoring your inflammatory bowel disease patients. So if you have a patient, like a case of IBS, and we're struggling with the IBS like Crohn's disease, you can just pop your probe, scan your bowel, and identify and know if the patient is having Crohn's or doesn't have Crohn's. Also, if you find the patient is having an inflammatory bowel disease, so you can know if the patient is having colonic or small bowel disease. And it's a very helpful tool for monitoring the patients and identify the complications that may happen. So intestinal ultrasound can play a role in every single phase of disease monitoring and following up the patients by pre-treatment assessments, by after drug induction, by in the maintenance phase, and also for monitoring and re-escalating the medications or readjusting the medications. And if you want to give the patient a drug holiday, also you can monitor the patient using the intestinal ultrasound. So bowel wall thickening is the main parameters. We have lots of parameters using the intestinal ultrasound. However, if you're going to look at it as a target, so in this image, this is a normal bowel wall thickening. We have 5 layers, but using the B mode, you can view the 3 layers. You can assess the mucosa, the submucosa, and the muscularis mucosa. You can assess the stratifications, and you can assess the disease activity checking the vascularity. So a simple comparison between the 2 images, even if you're not familiar with the ultrasound, with the scan images, you can see that the layering is clear with a thin wall. However, in the other pictures, it's partially disrupt the stratifications and the layering, and the wall is a bit thickened, and that indicates that the patient is having an active disease. Intestinal ultrasound can detect the disease activity, so like these cases, you can see this, the hypoechoic or the black loop. It's a terminal ileum, and this is a terminal ileal bowel wall thickening, and that gave us a clue that, okay, this patient may have some sort of Crohn's disease, as he's not like something else. And also we can check the disease activity by using the vascularity and the Limburg scoring, and it showed that the patient, confirmed that the patient is having an active disease. We compare it because everybody is asking about the accuracy, and when you compare it to the colonoscopy, you will find that it's almost comparable because this is the same patient and the ultrasound finding, and this is his endoscopy. So we got to know that the patient is having a sort of disease activity. And then evidence-wise, regarding the accuracy, so Mariangela Loca from Italy, and she's an IBIS member, she was comparing the intestinal ultrasound accuracy in identifying the Crohn's disease activity using the gold standard parameters, which is the MRE and the colonoscopy all the way together. And she found that it's very accurate, and the accuracy can reach up to 91%. And also it can identify the degree of the inflammations with a good percentage exceeding a 96%. We can also identify the complication, which we won't be able to identify using a straightforward colonoscopy. And again, from Netherlands, they were also trying to do some prospective trials in Crohn's disease patients, trying to know if the patient is the intestinal ultrasound is comparable to the colonoscopy, our gold standard. And with a cohort number of 51 patients, they found that the overall intestinal ultrasound is able to identify more than 86% of our IBD patients, and it can allocate and localize the disease activity in every single segment and identify the complications for sure. Same patients, he had a biological therapy, has been started, and then we decided to scan him. And this is the old one in which he was having the thickened bowel wall, like 6 months back. And when we repeat the intestinal ultrasound, again, there was no significant changes. It was like just few millimeter changes, and that gave us a clue that the patient is not responding. So we can use intestinal ultrasound in monitoring our patients. And regarding the monitoring, we would have asked like how fast we can do the intestinal ultrasounds for our patients, and everybody is familiar with the Stardust trials. But there is a sub-study with the Stardust trials that has been done by Thorsten. He's a governing board member at IBIS, in which he was following the Crohn's disease patients at week 0, week 4, week 8, and week 16. And this is what he found. After completing 48 years, he found that there will be a reduction in IUS response to your medications after 4 weeks of the introductions of the medication. And as he moves on with the days and the weeks, then the mucosal healing and the transmural remission, which was defined as a reduction of 25% of the bowel wall thickening, it was significantly significantly positive in a case with using the intestinal ultrasound, and this was applicable with the ileum and the colon. Complications. We hate complications. We don't like to see our patients having any sort of complications. This is a young patient of mine. He was having like a terminal ileal Crohn's disease. The patient was doing well. Okay. So he came with abdominal pain. He said, "Doctor, I'm okay. I would like to stop my medications." He stopped his medication and he disappeared as usual from the clinic. And then he showed up and I told him, "Why don't we do like intestinal ultrasound?" And we found that he has some sort of bowel wall thickening. And then I moved the probe all the way and I found that the stratification was there and there was like few pixels, and that gave me a clue that maybe this patient is having some sort of complications. And as I moved my probe, I found this object in the middle. It's three loops connecting together, and there is a hypoechoic lesions in between, and that indicates that the patient is having a small bowel fistula. And this is the MR enterography. It's almost similar finding because there was also 3 loops with a complex fistula, even pre and post enhancements. So instead of booking the patients for the MR enterography, next door you can use the intestinal ultrasound. And again, regarding the British trial, which is the METRIC trials, prospective trials, they were looking about they were comparing the MRE with the intestinal ultrasounds in identifying the Crohn's disease and to check for the relapse in those patients. And they found almost there was a comparable sensitivity and accuracy between the intestinal ultrasound and the MRE for both the colonic and small bowel disease. Again, for the complication, this is a wonderful systematic review from Netherlands. They included a huge number of articles and with a total number of patients exceeding it's almost 1,500, and also same finding. The B mode, this straightforward gray zone intestinal ultrasound, can identify all complications such as strictures, inflammatory mass, and fistula with a high sensitivity and specificity. That patient had a surgery, and then after a couple of months, he presented to the clinic and he said, "I'm doing well, I have no problems at all." When we scanned this patient, we found again that at the anastomotic site, Dr. Hamad wants me to show him, there is some sort of bowel wall thickening. And when we check the activity, again, the bowel wall is thickened and active. So early colonoscopy was done for the patient, and this is the exact finding. The patient is having an early recurrence, so early biological therapy has been introduced for him. So IUS can detect even the post-operative recurrence with a good and high sensitivity. The cutoff points of one of the parameters, which is the bowel wall thickening, cutoff point of 3 to 3.5 can give us a good clue about what's going on inside the bowel. Also, intestinal ultrasound can categorize the degree of severity for our IBD patient, because if we have a bowel wall thickening of more than 5 millimeters, that indicates we're dealing with a severe disease recurrence. Everything needs a scoring. For also, IBIS has published their score for Crohn's disease, and we're expecting in the future to have one for the ulcerative colitis. Not only in Crohn's disease, but nowadays also we're applying intestinal ultrasound in a case of ulcerative colitis. Again, we're following the bowel wall thickening, and we're checking the color Doppler for the patients, and we're comparing it with the endoscopy. We found also in a case of ulcerative colitis, the response for the medication is way faster than the Crohn's disease. Like within 2 weeks, you can see the difference. And also nowadays, we have a lot of trials that showed us that even in a complication such as acute severe UC, using intestinal ultrasound early can give you a clue about the patient response after 48 hours of steroid and the need for salvage therapy or the colectomy. The future is hiding a lot of things for us. We don't know because we know that the wheel of IBD management and treatment is like running very fast. So maybe in the near future, we may need the AI in order to monitor our IBD patients. Maybe the patient who are using Fitbit or smart watches can give us a clue with some reading about the disease activity. This is a nice trial that has been done for 56 patients. They were monitoring the patient using Fitbit. They were checking the heart rate, the sleep deficiency, and also the number of times that it wakes the patient up from sleep to go to the washroom. And then they were identifying the disease activity using this Fitbit. So will we use it in the near future? We never know. Other than this, at the point of care, I know we're talking about images, we're talking about intestinal ultrasound. A lot of my colleagues are very interested in using intestinal ultrasound, but maybe the patient will be able to scan himself by having a portable intestinal ultrasound. Our colleague Noah from University of Chicago, she was having a patient, she had a strong gut, to be honest, to send a patient with acute severe UC to home. And then she asked the patient to scan himself and to send the loops to them. And after following up the patients for a couple of weeks, the patient did not respond. She asked the patient to come back to hospital, and she did and the patient underwent a total colectomy. So will we use this one in the future? I think Mahmoud Mosley was like astonished. Other than this, we have a lot of novel biomarkers that we can use. We shouldn't only rely maybe in the CRP and the fecal calprotectin. We have a lot of like microRNA that can be found in the blood and in the stool that can give us a clue about the disease activity. Would it be like part of our investigation that we write down in the clinic? You never know. Also, there is some sort of calculations between the neutrophil to the lymphocyte ratio. It's a hematological marker. It can give you a clue about the response to biological therapy, and it can predict the outcome using the endoscopy. The future is hiding a lot. We're talking nowadays about the transmural healing, and we're hoping that it will be included as a parameter and as a long-term target. However, possibly we may think beyond this level, like using the PET scan FDG. This is a small trial for a UC patient. They were only 10. 4 of them, they were all in remission. 4 of them had some sort of uptake. And then they were asking themselves that would the PET scan be helpful to give us a way early clue about what's going on to the bowel, even before having transmural disease. Other genetic testing that just Gareth told us about, and a lot of things are coming down the pipeline. Will we be able to rely on such investigations to monitor and to diagnose our patients? It's still kept for the future. So just to conclude and to wrap up, that we know that most of the international guidelines and the recommendations support the use of tight control regimen to evaluate our IBD patients. Mucosal healing using the endoscopy now is the main target, but maybe, possibly in the near future, the transmural healing may become a fundamental parameter in managing our IBD patients. We're asking for tight control and timely tight control to monitor our patients, because this can change the clinical decision and can modify the disease nature and the disease progression. Looking forward for the future, what is hiding for us in order to monitor, diagnose our patients, and to keep our patients in a clinical remission and better quality of life. And thank you.
Sorry. Thank you very much, Dr. Hiba, for this very elegant talk. We'll move to our next speaker or topic. Our next speaker is Dr. Ahmed Al-Ghamdi, who is a known gastroenterologist, the head of IBD section in King Fahd Medical City in Riyadh. He obtained his Canadian Fellowship in Inflammatory Bowel Disease in 2018 and has since published lots of papers in IBD as well as in gastroenterology in a very respectable journals. He is going to talk to us about caring of hospitalized patients with ulcerative colitis. The title is From Flare to Fear. So, Dr. Ahmed Al-Ghamdi, the floor is yours.
Not the presentation. Huh? So how can I see it here?
شوف اللي قدامه واللي قدامه.
لا لا هنا أفضل شيء ماني شايف. So, Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. Thank you for the nice introductions, and thank you for the scientific committee for inviting me to talk about one of the critical topic in IBD, caring for the hospitalized UC patients. So here is my disclosures and the objectives for the talk. Initially, we're going to start with the definition of the acute severe ulcerative colitis and the quick review of the diagnostic practices. Then address the management of the complications such as the infections and the steroid failure. And finally, we will discuss the risk stratification and the treatment option therapy. So we know that acute severe ulcerative colitis, it is a serious condition. And the definition is the presence of the 6 or more bowel movement accompanied by at least one of systemic sign of the toxicity, tachycardia, fever, anemia, or elevated inflammatory markers, either the ESR or C-reactive protein. So the acute severe ulcerative colitis is not a rare disease. It can affect 25% of the UC patient develop the acute severe ulcerative colitis. 30 to 40% of them, they will fail the steroid therapy, and 18% of the patient, they will acquire colectomy. So this is the ACG, proposed ulcerative colitis activity index, and they classify it to the 4 categories: the remission, mild, moderate, severe, and the fulminant, and they including the several markers here. And this is recently they add the urgency and the fecal calprotectin, and I think also the fecal calprotectin to be included here can help us in the our clinical practice. So the first day of the admission by the patients with the first day of admission of patients with acute severe ulcerative colitis, we will perform the blood test, CBC, electrolyte, CRB, ESR, and lipid profile. Then obtain the abdominal X-ray and consider the CT scan if it is indicated. Check the stool and rule out the infection, and the most important is the C. diff. And also do the flex sigmoidoscopy the second day unprepared to rule out CMV colitis, and test for tuberculosis and hepatitis B to prepare for any risk therapy, and investigate for the deep vein thrombosis and start prophylaxis, and consult the surgery early. Please keep the surgery on board from the first day. So one of the most important factor for the disease assessment and the disease course is the ulcer. So deep ulcer mean the patient is coarse and the high risk patients. So there are 3 main objectives from doing the flex sigmoidoscopy. The second day is the assess the inflammation severity, to confirm the IBD diagnosis if it is uncertain, and to rule out the CMV colitis. So the C. diff infection is really, it is something significant and serious consideration. So as the IBD patients increase the risk of 4.8 times to have a C. diff infection comparing to the non-IBD patient. And also those patients with the positive C. diff, they have increased risk of the colectomy almost 3 times to those patients without infection. There are some risk factors that increase the risk of the infection: more extensive disease, severe disease, and immunosuppression therapy. So the testing for C. diff is a little bit complicated with the multi-step testing algorithm, including the both high sensitive and specific test, and should be used for the diagnosis. However, the treatment should not be withheld when there is high clinical suspicion, even if the test is negative. So regarding the treatment, the vancomycin is the first line therapy treatment in the C. diff in IBD patients, and metronidazole should not be used, even if it is the first episode. And one important point here, that you will treat both UC and C. diff at the same time. Also, regarding the antibiotic course, we give a little bit longer than around more than 3 weeks, because this will decrease the risk of the recurrence. Regarding the CMV colitis, also this is another important infection that should be addressed during the acute severe ulcerative colitis. We know that active UC will increase the risk of the CMV colitis, and the CMV colitis will worsen the activity of the UC. So the questions here is treat active UC first, or you will treat the CMV colitis, or you will treat both at the same time. CMV also is not a rare disease. The prevalence reach up to the 38% over all the prevalence, and reach up to the 34% in severe ulcerative colitis, and more common in steroid refractory colitis. There are some risk factors for the CMV colitis: female gender, pancolitis, age more than 30 years, disease duration less than 5 years, exposure to the immunosuppression therapy, and high dose of steroid. So regarding the CMV infection, there are 3 clinical spectrum of the CMV. CMV infection, that means the presence of the CMV antigen or antibody in the blood. CMV colitis, that means the presence of the virus in the colon inside of the inflamed tissue without damage the tissue, and this is what we call the innocent bystander. And the last one is the CMV disease, the symptomatic end organ detection, clinical symptoms, and tissue damage. So regarding the treatment plan of the CMV infection, it's really depend on the clinical spectrum. So if we go from the latent to the disseminated or the CMV disease, usually the patient will get a benefit from starting the antiviral therapy, while those patients with the latent and CMV colitis will get a benefit from treating the disease activity. So here is the summary for the treatment of the CMV colitis. When you suspect about the diagnosis, if you have acute severe ulcerative colitis, patient with steroid and thiopurine refractory disease, and deep ulceration in the endoscopy. So you will send for or to confirm a diagnosis by the histology or by immunohistochemistry or the tissue PCR in the colon. So the treatments, actually, it's depend on the immunohistochemistry inclusion bodies. So those with the more than 5 inclusion bodies, they consider as high-grade disease. So we consider the CMV treatment and start the antiviral therapy, taper the steroid, and consider stopping the thiopurine, but the anti-TNF is safe. Those patients with the low-grade infection, that means you will treat the disease activity other than the virus. It's really another important point here that those patients that admitted with acute severe ulcerative colitis, the DVT prophylaxis. So this is a retrospective study including more than 300 UC patients admitted between 2007 to 2011. And the overall, the DVT prophylaxis is 67%. While the prophylaxis in the medical patients is around 57, while in the surgical patients is 93%. So the surgery, they are doing better than us. In the missed dose in the medical patient is a 34%, and the missed dose in the surgical patient is 17%. So this is highlight the importance of the giving the DVT prophylaxis, as we know that those patients that admitted with the acute severe ulcerative colitis, they have a higher risk than those patients in non-active disease. So since 1955, still the cortisone is the primary treatment for the severe UC. And this is a small study that compared the hydrocortisone 100 versus the placebo. That time showed the clinical remission is a 41% comparing to the 16% in placebo group, and the mortality is less in steroid group, 7% comparing to the 24%. So around 67 of the patients receiving steroid treatment show positive clinical response. So the ACG guideline recommend a total of 60 milligram methylbrite or hydrocortisone 100 milligram to induce remission. So from the second and the third day, we need to evaluate the daily symptoms, monitor the inflammatory marker, especially the CRP, do the abdominal X-ray if it is indicated, assess for the response to the IV steroid using the predictive markers, and for those patients that respond to the steroid may continue IV steroid for 3 to 5 days, then consider the switch to the oral prednisolone. For those patients that not responding to the steroid by day 2 to 3, you should consider the rescue therapy. So here is some markers that can help us and predict the steroid failure and the need for the rescue therapy. One of them, the Oxford criteria, that the stool frequency more than 8 times or stool frequency more than 3 with the CRP more than 5. This can tell us that around 85% of the patient, they will have colectomy. So there are two main important medication for the rescue therapy, the infliximab and the cyclosporin. And we know that infliximab and cyclosporin, both they are effective in the treatment of the steroid refractory acute severe UC. And this study showed that around 115 patients, they comparing the infliximab versus the cyclosporin, and in the term of the treatment failure, colectomy rate, severe adverse event, steroid-free remissions, and clinical response, there were no difference between the two medications. So those two medications is effective treatment for the rescue therapy with the same efficacy. As we know that to choose between these two medications, there is a potential contraindication for each one. Infliximab, the untreated latent TB, congestive heart failure, demyelinating disease, and active infection, except the C. diff. In cyclosporin, this will decrease the threshold for the seizure, renal insufficiency, low cholesterol level, active infection, and lack of the local expertise in the administrations and monitoring of the cyclosporin. So it's very important to know that the low albumin and the elevated CRP level will impact on the infliximab exposures. So as we can see here that those patients with the high CRP, the concentration of the infliximab is around 500, while those patients with less CRP or less than 50, it's increased more than doubling, more than 1,000. So there is increase of the infliximab clearance with the high CRP, and in albumin also we see the same one with the low albumin. There is decrease of the infliximab exposure, but it is less significant than CRP. So what about giving IV albumin with the infliximab, if this will help the infliximab exposures treatment outcome? So this is a study, then a single center randomized control trial of the 61 patients, and the two groups, one of the albumin arm and the standard arm, and they found there is no difference between the two groups in the term of steroid failure rate and also in colectomy rate. So the evidence showed there is no benefit from giving IV albumin to those patients with the acute severe ulcerative colitis. So as we know that there is clearance, there is leakage of the drug. So what about to increasing the dose? So if there is leakage of drug, so does more mean better? This is a recent published study called PREDICT-UC. It is an open-label, multi-center randomized control trial. They include around 138 patients with the steroid refractory acute severe UC. As you can see here from the study design, this is one of the most complex study design. So they start with the first randomization of the patients. They divided to two groups, the standard dose and the intensified dose. In the standard dose, they give 5 milligram per kg, while the intensified, they give 10 milligram. Then for the standardized group, they do another randomization to standardized induction and accelerated induction. In the standardized induction, they give 5 milligram at week 0 to 6, and if there is no response, they will give another 5 between day 3 to 7. In accelerated induction dose, they give 5 milligram 013. If there is no response, they will give 10. So what about the outcome? The outcome between the standardized and intensified and the accelerated, as you can see, there was no difference in the clinical response by day 7 and day 14. There is no difference in the clinical remission, endoscopic remissions, and also in steroid-free remission, and in the colectomy rate. So there showing there is no added benefit from the intensified or the accelerated dose, and as we can see here also the p-value is non-significant. So what about the subgroup of the patient that they have high CRP and low albumin? This is the post hoc analysis from the PREDICT UC, and showed also there is no benefit from adding the intensified dose 10 milligram in those patients with low albumin and high CRP. Numerically is better, but statistically non-significant. So now we're going to move to the another modalities of the treatments, another mechanism, the JAK. So this is a tofacitinib in the acute severe ulcerative colitis, as we can see here in the single center study, around 100 patients. They divided in two groups, tofacitinib 10 milligram 3 times a day versus the placebo for the 7 days. As we can see here, there is a signal of the benefit from the tofacitinib in patients with acute severe ulcerative colitis, as we can see here, and also in the need for the rescue therapy. And regarding the colectomy rate, it is less in the tofacitinib group comparing to the placebo group, and also this is statistically significant. The upadacitinib also, there is a promise that may get a benefit from the treat the patients with upadacitinib. In this study, the 100 of the patients, they already infliximab exposed. As we can see here, that the 90 days colectomy rate is 24%, steroid-free remission is 83%, venous thromboembolism event is 4%. So there is a signal that upadacitinib is a promise and working for the acute severe ulcerative colitis. So what about the third line? If we failed the first line steroid and the second line of the infliximab or cyclosporine, is there any role for the third line? This is assessed in this multi-center retrospective cohort study. As we can see, here is around 78 patients, 32 infliximab and 46 cyclosporine. And those group in the infliximab, 17 of them, they received cyclosporine, 13 tofacitinib, and 2 ustekinumab. And in the cyclosporine group, 45 infliximab and 1 ustekinumab. So as we can see here, that around 50% of the patient, they response, clinically response, and also the colectomy-free survival is around 50%. So this is the network meta-analysis. As you know, the network meta-analysis, it is the indirect comparison between the medications. As we can see here that tofacitinib, accelerated infliximab, standardized infliximab dose, and tacrolimus, they significantly reduce the rate of the colectomy in patients with steroid refractory acute severe UC compared to the placebo. So between the day 7, between the day 4 and 7, we need again to decide whether to continue the medical therapy or consider surgery, reassess the patient condition. For those on rescue therapy, evaluate the response and consider next. And next step, either to continue the treatment, switch another therapy, or proceed to surgery. So this is an important post-hoc analysis from the TRIUMPH study that there is a predictor at the day 7. And they found that if the rectal bleeding subscore is 0 by the day 7, the clinical remission is reached up to the 75%, and the endoscopic improvement is 62%. So the rectal bleeding subscore by day 7 was significantly associated with week 26 steroid remission and endoscopic improvement. So what about the follow-up? This is interesting study that the impact of the timing of gastroenterology follow-up on the readmission rate after the admission of the severe UC. And they found those patients that seen after 1 week from the discharge to be without readmission is reached up to the 76% comparing to the other group that saw the patient after 2 weeks or more than this. So this is an emergent therapy in the treatment of the acute severe UC, the hyperbaric oxygen therapy. And as we can see here is a phase 2A randomized double-blind study. They include around 18 patients with the two group, the hyperbaric oxygen versus the placebo, and it was better in the clinical remission at day 5 and clinical response at day 10. But there was no difference in the colectomy. So this study is still going on, and also there is a signal that maybe this is we will have some modalities of the treatment in the future. So the conclusion, the acute severe UC is a serious condition affecting about 25% of the patients, and 40% of them, they were not responding to the therapy, and 18 requiring the colectomy. Early diagnosis, risk stratification, and multidisciplinary management are crucial for the optimum outcome. Steroid remain the first line therapy. The infliximab and cyclosporine both are equally and effective as a rescue therapy. Emerging therapy, the JAK inhibitors like the tofacitinib and upadacitinib may consider in the treatment. And also the novel approach like the hyperbaric oxygen therapy may offer additional benefit in the managing of the severe UC. Also the follow-up after the discharge is significantly reduced the admission rate for the UC patients. Thank you.
Thank you so much for the outstanding presentation. We'll take questions at the end. And we will end this first session with a somehow different presentation. It's a debate. And I would like to welcome Professor Mahmoud Mosley, who is currently an associate professor of medicine and a consultant gastroenterologist specialized in inflammatory bowel disease at the Department of Medicine at King Abdulaziz.
Before the debate? Okay, yeah, sure. طبعا حماد حبيبنا هو لازم he has to open the yes please.
better than the first line. So we should start the first line. Is that better or not? And what about combination therapy? Where are we for cure?
Well, I'm not sure if this mic is live. Hello? Oh, there it is. So combination therapy, I'm talking on tomorrow, so I'm so glad you brought it up, but I don't want to give the game away. I want people to come back tomorrow morning for that session. So we're going to talk about that, and I think it is very interesting. We're going to talk about how we can break this glass ceiling. I don't think I said that second-line therapy is necessarily better than first. I think my take-home of the last year is that early therapy, early effective therapy, actually if all the drugs cost the same, and I tried to do that in my practical steps, if all the drugs cost the same, for those patients I'd be happy with an anti-TNF or an IL-23. I think you just need to, with the JAK inhibitors, be a bit aware of the possibility of side effects. So we've been using it. We can still use it as a first-line therapy, and there are times where we do that, but we use it more commonly as a second line. So I'm happy with any effective agent, but don't delay. And I think what Heba showed really nicely is don't stop it, because it's those patients who stop and then disappear, and then they come back with complications. You need to stay ahead of the inflammation.
So UC with PSC, what is your first line?
That
debate. Okay. For Hiba, my always star is Hiba. So Hiba, I have a patient which is very interesting, 59. She was roaming around eating burgers and shawarmas and everything, and suddenly she had diarrhea 10 times with some abdominal pain. So we did the stool analysis, we did ESR and CRP, and we did fecal calprotectin, was 4,300, and the fit testing was 2,300. There was a bit delay. I don't have these tests. It is done in outside. So I gave her furazole, which is combination of metronidazole with existing diloxinate furoate, and I gave her Cipro. And I told her, take the medication, and we'll see. There was a delay in the colonoscopy appointment. After 10 days, ESR was high, 150, and the CRP was almost 170. So, and her white blood count were normal, albumin was normal. So I gave her ciproflagyl. After 1 week, she called me, Doctor, I'm perfect. I don't need colonoscopy. And she's 59. I told her the fit testing is high. We did the C. diff was negative. And intamoeba histolytica, trophozoid and cyst were positive. So I told her, are you willing to pay another 400 riyals and let's do the fit testing and fecal calprotectin? Said, I will not do colonoscopy, I am normal. So we repeated the fit testing, and from 2,300, it came back to 15. And calprotectin from 4,000, it came back to be 49. And she said, Doctor, I told you, I don't need colonoscopy. So we convinced her, one of my colleagues here, we convinced her, she's a lady, she wanted a lady doctor.
Hamad, that became
so calprotectin, CRP came normal, ESR came normal.
Your question, please.
My question is, in Saudi, we have amoebic dysentery. So I think we should not do the calprotectin and fit testing unless we give them a trial of 10 days of furazole. What do you think? It came back to normal.
Quick answer, please.
Thank you, Dr. Hamad. Honestly, we missed you last year. So from what you said, you're expecting like an infection in this patient. And I told earlier, like, even if it's IBD or non-IBD, the biochemical parameters that we're using on a regular basis is the CRP and the fecal calprotectin is not specifically 100% related to IBD. So this will give you a clue that there is something and some sort of inflammation. However, infection could be part of it. But covering first of all, digging on the history further is a very important thing because this patient came with a really short duration of disease activity. So we shouldn't label her as a case of IBD. However, the chronicity is something really important for our IBD patients. So if you have a patient with an extensive history, with elements of chronicity, and you're 100% sure that he is having an IBD, then those guys, you won't consider starting antibiotic at the first instant unless you rule out infections. And even with our IBD patients, when we do always send cultures and we do always send stool analysis for those patients to confirm that they don't have anything before starting steroid and biological therapy. So I respect your opinion on starting antibiotic, but it's not applicable for all patients.
It came back
especially
to
when
normal.
it comes
So
to IBD.
what my point in Saudi is...
Sorry to interrupt, Dr. Hamad. I'm really sorry to interrupt, but we're up against the clock. I think we need to move to the debate. So the debate is next. Dr. Al-Wardi will start, and with Professor Mosul. Okay, thank you so much.
Okay,
the last presentation, it will be somehow different. It will be a debate. We're expecting from two very experienced and IBD experts, from Professor Mahmoud Mosley, who is currently an associate professor of medicine and consultant gastroenterologist, specialized in IBD at the Department of Medicine at King Abdulaziz University Hospital in Jeddah, and from Dr. Al-Bardi, who is a consultant gastroenterologist and IBD specialist at King Faisal Specialist Hospital and Research Center in Riyadh. We're expecting a peaceful fight and a didactic debate about the first-line advanced therapy in UC, in ulcerative colitis, biologic versus small molecules. Please, Professor Mahmoud.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. It's my absolute pleasure to be with you today, and I want to start by congratulating the organizers and thanking them for the opportunity to talk to you today. So this will take on a debate format. So really the purpose of the debate is to try to challenge our traditional dogma. So it's not to say that one class of drug is better than the other, but in my end, it's to convince you that the way to go is small molecules, and particularly as first line in UC. So these are my disclosures. These are the objectives of the talk. First, I'd like to review the limitations of our current biologic therapies. We'd like to distinguish some of the basic characteristics of small molecules and biologics, and then we'll compare effectiveness, safety, and also patient preference in terms of biologics and small molecules in UC. So I'm going to start out with a case. This is a 25-year-old man with ulcerative pancolitis for 3 years. He's been on mesalamine for 2 years. Then he developed a steroid-dependent flare. So he's coming to you now with up to 8 bloody bowel movements a day. He's lost about 4 kilograms in the past 6 months. You're not able to taper the steroids off, and as you can see in this case, unfortunately, he remained on steroids for quite some time, up to 5 months now. He has some peripheral joint pains, but no other extraintestinal manifestations. This is some of his social and medication and family history. So you do the basic workup. His C. diff is negative, CMV is negative, and as you note in his labs, his albumin is 2.9, CRP is 55, and his fecal calprotectin is over 1400. So these are images of his colonoscopy showing a Mayo UC endoscopic score of 3. So I'm going to start by posing a question to the audience. So if you are seeing this patient in your practice, this is an advanced therapy naive patient, which of these agents would you reach to as first line? So I'm going to have you kind of glance through the different options. Then I'm going to take a poll of the audience and I'm going to repeat the same case at the end of the presentation. So how many would go with A, infliximab and azathioprine? We have a few takers. What about vedolizumab, first line? Less than infliximab. What about an IL-12/23 or IL-23 receptor blocker? Less than vedolizumab. What about upadacitinib? Okay, definitely less, only a couple there. Tofacitinib? Less. And then what about S1P receptor modulators? So let's say ozanimod, etrasimod, both of these options. Great, 0. Okay, so We have been blessed over the past decade with the expansion of the therapeutic armamentarium to treat both Crohn's disease and UC. And for the purpose of my talk, I'll be focusing on UC. And you'll note that up to 2014, we only had anti-TNFs as advanced therapies. But really the pivotal moment, I think, or the biggest milestone in these advanced therapies is the introduction of small molecules, particularly with tofacitinib in 2018 for UC. Now, there's some important differences between small molecules and biologics, so I won't go through all the details in this table, but small molecules, as the name implies, these are small molecules. They undergo a chemical process. In terms of their complexity, they're actually less complex than biologics. They're well-defined hydrocarbons. They're easier to store at room temperature versus refrigeration for biologics. Their metabolism is extremely different than biologics, right? This is hepatic and renal metabolism versus proteolysis. And the neat thing about these small molecules is they have a very short half-life, so quick on and quick off. And the route of administration is particularly different. These are oral molecules. So let me start out by highlighting the limitation of anti-TNF therapies. So we know that the anti-TNF remission rate usually does not exceed 40 to 50%. But the problem with anti-TNFs is the primary non-response can be noted in up to a third of patients. The secondary loss of response can be noted in up to 40%. And the annual loss of response happens on a rate of about 10%. And part of the reason we have this annual loss of response is drug antibodies. And if we look at the PANSS trial for Crohn's disease, we note that up to 2/3 of patients on infliximab will develop antibodies, and about 1/3 of patients on adalimumab will develop antibodies. So this forces us as clinicians, especially when we use infliximab, to use it in combination therapy with an immunomodulator to decrease immunogenicity. But we know once we start combining anti-TNF with an immunomodulator, we end up with higher risk of adverse events, and particularly risk of infection. And this is a study, a large study, a French national health study, which showed that in comparison to thiopurine monotherapy, anti-TNF monotherapy, combination therapy is associated with higher risk of serious infections, particularly opportunistic infections. And this is also a study from France looking at a national health-based system. And in this one is looking at the risk of lymphoma with anti-TNFs and anti-TNF combination therapy. So if you look at just anti-TNF monotherapy, there is a slight increase in the risk of lymphoma. But then when you look at the combination therapy of anti-TNF and immunomodulator, then this is really when you see the risk of lymphoma appear. Now, this is a concept that was briefly touched based on in the previous nice talk by Dr. Al-Ghamdi on acute severe UC. And when I can even expand this, I would say, argument beyond anti-TNFs, it's really all biologics. The problem with biologics, particularly in IBD, is the higher disease activity, the higher the clearance. And really the clearance is dependent on albumin. So if you look at even beyond anti-TNFs, so if we look at the IL-12/23 inhibitors, ustekinumab, low albumin is associated with higher drug clearance. However, if we look at small molecules, particularly tofacitinib in this study, baseline albumin was not a significant predictor of the drug's efficacy. So when we're selecting a therapeutic option for our patients with UC, in my mind, there are really four important factors. We're looking at the efficacy of the drug, we're looking at the safety of the drug, we're looking at patient-related factors, and we're looking at disease-related factors. So my four arguments going forward is there are four important things. Number one, effectiveness of small molecules. 2, onset of action. 3, safety of these molecules. And then 4, patient preference. So let's go over efficacy. And when we're looking at comparative efficacy, and this was discussed slightly earlier, we can compare either head-to-head clinical trials, systematic reviews and network meta-analysis, or real-world comparative studies. Now, we don't have head-to-head trials comparing small molecules to biologics, but there's a couple of real-world studies and systematic reviews that I'll touch base on. So this was a multi-center retrospective cohort from the US looking at the comparative effectiveness of upadacitinib versus ustekinumab. And this was a mixed population. For example, if we look at the ustekinumab population here, some of them were actually bio-naive or therapeutic advanced therapy naive, but all the upadacitinib patients were exposed. So you can make an argument that the upadacitinib population here was sicker. Despite that, you can see almost double the rate of steroid-free clinical remission with upadacitinib compared to ustekinumab, and also almost double the rate of hard outcomes such as endoscopic remission. And when they've controlled for confounding factors, you find that the clinical response rate, almost 2 times odds ratio, and for steroid-free clinical remission rate, almost 3 times. But again, looking at hard outcomes, endoscopic remission was almost 5 times. Now, this study looked at the pivotal clinical trials and compared upadacitinib to other biologics and tofacitinib. And what this study showed us is that when we compare upadacitinib to vedolizumab or to ustekinumab, which is I'm going to focus on, and these were the outcomes, either clinical response, remission, or endoscopic improvement, and there was significant difference in the proportion in terms of achieving these outcomes in favor of upadacitinib. And if you look at the number to treat, these are small numbers. As you remember that the lower the numbers to treat, the better or the higher the magnitude of effect. So this is showing us that upadacitinib is better than vedolizumab and better than ustekinumab. Now, what about systematic reviews and network meta-analysis? These were discussed earlier by Dr. Parks in his talk. And there are multiple of these network meta-analyses done. So this is the one from 2021. And if we look at induction of clinical remission, upadacitinib ranked highest. If we looked at induction of endoscopic improvement, we can see that infliximab ranked highest, but unfortunately you would have to use off-label dosing of 10 milligrams per kilogram. Now, more recently, Dr. Mohammed Shihab, who's in the audience, has published his updated systematic review network meta-analysis in CGH. This included 36 studies, over 14,000 patients, and again, the same conclusion, upadacitinib 45 milligrams, and this is again a hard outcome of induction of endoscopic improvement, was better than the anti-TNF biologics, IL-12/23 receptor inhibitors, except risankizumab and tofacitinib, they were pretty similar. And this is the SUCRA, and you can see that upadacitinib ranked highest. And again, I'd like to also emphasize the limitation of network meta-analysis. We're comparing different patient populations, trials done in different decades, different endpoints. So we talked about efficacy. What about safety? So Mahmoud is going to try to convince you that these drugs are not safe. But let me tell you this brief story of how this safety saga started, right? So this is the oral surveillance study. This looked at cardiovascular and cancer risk in tofacitinib in RA patients compared to anti-TNF. And what did they find in this study? Yes, there was a higher risk of MACE and malignancy, excluding non-melanoma skin cancer. But what's the patient population? These were RA patients over the age of 50 with at least one cardiovascular disease risk factor, not IBD. And the other thing, some of these patients were also on methotrexate. So what about the safety in IBD patients? And the main thing here, that there was a worry before even the publication of the oral surveillance study about DVTs and PEs, and this is how tofacitinib landed with a black box warning, which is now, for example, in certain countries, including the US, is only used as second line after anti-TNF failure. So what's the risk of venous thromboembolism in UC patients? So this is the baseline risk, not on any treatment. The incidence ratio can approach 0.3 for DVT. The incidence ratio can approach 0.2 for PE. So let's add on tofacitinib. And this is data from the pivotal clinical trial. And as you can see that these ratios are actually comparable. So 0.04 for DVT with tofa, 0.3, 0.16, 0.2. So they are comparable. And if you dig deep into the data, you'll see that all the patients who developed a DVT-PE in the pivotal clinical trial with UC, they had additional risk factors for DVT-PE. So do you want long-term safety? There is long-term safety data for tofacitinib. This is 7 years of treatment, over 2,400 patient years of exposure. And let's look at some of these adverse events of interest. So we'll start from the bottom of this table. We don't see an increased risk of DVT or PE in the UC patients who receive tofacitinib. We definitely don't see a risk of MACE. We don't see a risk of malignancies. So this is the patient population that we do see. True, there might be a higher risk of herpes zoster infection, but remember, these were unvaccinated patients. So what about upadacitinib? Again, we'll go through some of these adverse events of interest. No increased risk of MACE or VTE. No increased risk of malignancy. And again, herpes zoster, you can see that, but these were unvaccinated patients. So there was a big meta-analysis of JAK inhibitors across all different indications. So we're looking at JAKs, anti-TNF agents across different indications. This is not only limited to IBD, but also rheumatologic conditions, 62 randomized controlled trials, 16 long-term extension trials, over 82,000 person-years of exposure. So it's lots of exposure to JAK inhibitors. And what does this study find? Well, JAK inhibitors versus placebo, no increased risk of cancer. JAK inhibitors versus methotrexate, no increased risk of malignancy. So my third point is onset of action. And we know that tofacitinib has a very rapid onset of action from this post hoc analysis of the pivotal trial. We can see the separation between placebo and tofacitinib within only 3 days. You can see the PROs are different within 3 days. You can see that separation. 3 days is very rapid. But even with upadacitinib, you can see even a faster response. Within 1 day, you can start seeing the separation. And this is a very hard endpoint. This is a rectal bleeding score of 0. So this is not even improvement. This is complete remission in terms of rectal bleeding scores. And there were multiple network meta-analyses and systematic reviews to compare the onset of action of these drugs. And if we look at this bar graph, what we're looking at here, let me go back. So week 2, week 4, week 6, and you can see that upadacitinib ranks highest in terms of onset of action compared to the biologics. So far, I'm hoping I convinced you that these are effective drugs, they have a rapid onset of action, and they're also safe. And I'm not going to go over the acute severe UC. There's a nice data that was already presented by Dr. Al-Ghamdi, but considering that these drugs have a very rapid onset of action, they also will likely have a significant impact in treatment of patients with acute severe UC, particularly as first line. And this is data for tofacitinib and also data for upadacitinib was presented earlier, so I'm not going to go over the details. Finally, route of administration. And this is really an important point for our patients. This is a large multi-center study, almost 700 patients in Europe. And the rationale of this study is they wanted to understand the patient's preferences in terms of choosing a therapy. And what patients focus on, or what they answer to the most, is route of administration. This was the most important factor to patients in terms of picking therapy. And when they asked deeper about the different routes of administration, particularly in UC patients, significantly more patients were in favor of oral pills rather than injectables or IV. Now, this study was done in Europe. What about a study done in our area? This is a really fantastic study that was led by Dr. Uthman Harbi and our own Dr. Mahmoud Musli. And Dr. Mahmoud will tell you the results of the study show majority of patients actually favor oral medications. So you didn't hear it from me, you heard it from Dr. Mahmoud. Finally, so this is my summary. So why would you pick a small molecule as first line? Number one, no immunogenicity. No need to combine with an immunomodulator and the complexity of monitoring. Rapid onset of action. It's an oral agent. Patients prefer that. The best drug is the one that the patient will take and will stay on for long term. Finally, effectiveness and safety. So let me go back to our patients. And I'm going to summarize. This is the presentation of our patient. And this is the endoscopy, and I'm going to ask the question again. If you're seeing this patient in your practice, and there's going to be two options here. You're either going to go biologic or small molecule. So how many would vote biologic? I can't, okay, Mahmoud, you can't vote. How many would vote small molecule? Upadacitinib. Thank you. Thank you for your attention.
Dr. Bawardi, for this very elegant, you convinced us actually. I should say that before even we hear Mahmoud, but I'm sure Mahmoud has made some surprises to tell us about. Professor Mahmoud is going now to shift the gear to biologics. Professor Mahmoud, the floor is yours.
لا بس ما تظهر هنا ما هي جيدة السلايدز ما هي ظاهرة هنا عندي بس هناك؟ اوكي طيب. اي اوكي طيب. بسم الله الرحمن الرحيم. Good afternoon. First of all, I'm very glad to be here today among colleagues and friends. It's an honor. And I'd like to first of all thank the previous speakers for some wonderful talks. And I'm very happy to be part of this heated debate with my friend, Dr. Badr. My goal or my task is to argue in favor of biologics over small molecules as first-line therapy for ulcerative colitis, and that's what I'm going to do. It won't take me long. It's a very easy task. So these are my objectives. So starting with an introduction, advanced therapy for UC. I'll go over some indication and types, illustrate differences between biologics and non-biologics, discuss attributes of each category of advanced treatment, compare the safety and efficacy of biologics and non-biologics, and present the rationale for choosing biologics over non-biologics as first-line therapy. And as Badr said, it's a real matter of perspective, not necessarily a solid rule written in stone. These are my disclosures. Now, my mentor once told me the first step in a scientific debate is very easy. You simply have to discredit your opponent. So I went online, I tried hard to find things on my opponent to use, but the only thing I can find is that this is a very, very smart, polite, extremely charming physician. The only thing I found very disturbing that he's always smiling. So all I can say is beware of those who are always smiling. Now, this is a study published a long time ago by our colleague, Dr. Uthman al-Harbi, about the epidemiology of ulcerative colitis in Saudi Arabia. And what you can see is that the majority of patients are diagnosed between 20 and 40 years of age. So this is an age where patients are the most physically active, the most sexually active, females are most likely to conceive, they contribute the most to society, and are really, really conscious about their appearance, especially teenagers. Dr. Badr already told us about things to consider when you choose advanced therapy. So things, of course, like efficacy, which he spent a long time talking about, speed of action, durability, patient preference, safety profile, need for combination therapy, EIMs, and potential for pregnancy in a patient. The perfect therapy for UC, which is still non-existent, is a therapy that is effective, works fast to control symptoms, but at the same time is safe, extremely tolerable, durable, and very convenient according to patients. Over the past few years, we saw in the previous talk that a lot of drugs have developed and been licensed for both diseases. I'm not going to spend time talking about that. Now, the first question that comes to mind, are biologics effective? Do they work? This is the first randomized controlled trial for ulcerative colitis, for a biologic therapy in ulcerative colitis, infliximab, which is Act 1. As you can see here, I don't know if it's showing, but this was published in 2005, 20 years ago. So this is a drug we know well, and we know it works. Lots of studies have been done. We know it's effective. There's no doubt about that. Vedolizumab, once a new drug, the new kid on the block. Well, now it's not so new, and it's actually been around for quite some time. There's lots and lots of literature to tell us that this is a very effective drug, specifically in patients who have more moderate disease than severe. Ustekinumab, another very effective agent for ulcerative colitis. And as you can see here, there's a lot of literature to support its significant efficacy in these patients. There's new agents, new biologics, not just anti-TNF. So we have the anti-IL-23 inhibitors for P19. So number one, we have mirikizumab, recently approved for ulcerative colitis for induction and maintenance. As you can see, this is the LUCENT-2 program, which met all outcomes, primary and secondary. What I'd like to point out, if you can pay attention to the bottom figures, is patients did better when they're naive to other biologics and to tofacitinib. Another reason to consider these agents in all biologics, because this has been consistently reproduced in several studies as first line before you proceed to a small molecule. Finally, risankizumab, soon to be approved for ulcerative colitis, in COMMAND, the study had met all outcomes or endpoints. I'm not going to dwell on that. We didn't hear about EIMs in the previous talk. EIMs happen in about 20 to 25% of patients. And it's really important for a drug that works on the luminal aspect of the disease to also work on EIMs. The most common EIM is, as we all know, joint involvement. And if you can see here in this breakdown in this table, while the majority of first-line therapy for EIMs and IBD are local therapies and anti-inflammatories, biologics constitute the majority of both second and third-line therapies, as it does JAK inhibitors in this case. I was at a talk last week in a different conference, and there was a quote that I really loved hearing. Efficacy is important, but safety is crucial. Do no harm, as we all do in medicine. So we need to focus more on safety when we choose our therapies. We heard about risk of infection with biologics. Is it true or is it a myth? When you look at individual studies, you might find signals here and there, but if you look at the totality of evidence, so individual RCTs, I'm sorry, there's some animation that's not showing, so individual RCTs, meta-analyses, not network meta-analyses. Meta-analysis show us there's really no association with infection. The only set of data that tells us this is safety registries. And again, these are really associations and there's no clear causative relationship. So we believe that the risk that have been quoted with biologics is probably an exaggeration. Does this slide seem familiar? It was shown in the previous talk, and Dr. Badr alluded to some of the risks associated with biologics. What he didn't show is this. The risk of malignancy with biologics, comparing JAK to anti-TNF, is higher with JAK inhibitors compared to the anti-TNF. Did anybody notice that? I don't think so. We didn't hear about pregnancy. I told you, these are the patients diagnosed in the age where they're more likely to be pregnant. There's a lot of concerns about biologics and pregnancy, but over the years, you can see how many studies and how many participants were tested. And the conclusion was, patients with IBD treated with biologics are almost have the exact same risk of developing poor outcomes as the general population. So biologics are extremely safe in pregnancy. We heard about durability. It's really important for a therapy to work, but to continue to work with time. Now, we do know here that there's a concern about anti-TNF agents being non-durable. We heard about loss of response. We heard about immunogenicity as a cause. And we do know that tofacitinib or small molecules, specifically JAKs, are very durable. But if you can look here and compare between, on the left side, vedolizumab and ustekinumab, they're actually more durable or equally durable as tofacitinib. So that's not one reason to advance this choice over the other. So in summary, what I've told you so far is that biologics are effective, safe. There's a very long-term experience with some of these biologics. They're safe in pregnancy. They treat EIM effectively. They're durable. And I might add, there's convenient dosing and administration, and we'll come back to that later. So let's talk about small molecules from my perspective. So there's a lot of JAK inhibitors out there, and I'd like to just mention, I won't be talking about S1P1 inhibitors since they're not available in our country. So there's several JAK inhibitors available in the market for different indications. In ulcerative colitis, there's these three, tofacitinib, filgotinib, and upadacitinib, with different forms of selectivity. I'm not going to spend time talking about efficacy. We've heard a lot about efficacy of these agents. You can see these are the major trials. There's no doubt these are very efficacious agents. I'm going to focus more on safety. Now, like I said, there's different forms of selectivity when it comes to JAK inhibitors. There's a belief that non-selective JAK inhibitors may have greater toxicity when compared to those that are selective. We did see Dr. Badr present this, so increased risk of cardiovascular disease with JAK inhibitors in rheumatoid arthritis patients from the oral surveillance program. This was the beginning of a concern raised by the scientific community about JAK inhibitors. Data coming out of the oral surveillance program continue to show us more data. So there's an increased risk of cancer that is initially reported. It's not dose dependent, indicating it's probably something related to the mechanism of action rather than saturation of receptors. As you can see, there's more than 1.5-fold increase in the risk of cancer with these agents. This sparked more interest. More data started to be collected, and there was also reports that these agents increase the risk of malignant skin tumors. This is based on the FAIRS data set, which is a real-world registry talking about or collecting data about JAK inhibitors and different forms of side effects. So here, data told us there's an increased risk of neoplasms in the skin. Of course, lots of studies, meta-analyses have been done, and as you can see here in this one, the pooled JAK inhibitor data suggested that malignancy risk is actually lower in IBD patients compared to other indications, such as rheumatological diseases and etc. However, the risk of non-melanoma skin cancer specifically is higher with JAKs in this population of patients. So what we can conclude is that there might be a risk of malignancy with JAK inhibitors. It's not very concrete, but it's enough for us to be concerned. JAK inhibitors with higher selectivity toward JAK1 potentially offer a better safety profile when compared with non-selective JAK inhibitors, but longer-term data is still needed for us to be 100% sure. This is integrated summary on safety data from tofacitinib randomized controlled trials, so mainly Octave, and you can see here that there are some signals, but they do not really exceed an incidence rate of 1.5. So it's not a major concern, but it's still a concern. Nevertheless, this is a black box warning from both EMA and FDA for this class of medications that we need to pay attention to. Moving on to something else, not talked about that much, but for people in the audience who use JAK inhibitors, specifically upadacitinib, they probably know about this. So JAK inhibitors and acne. There's about 4-fold increase in the risk of acne with JAK inhibitors, more so with upadacitinib. And in a population of young patients, some are teenagers, you need to point that out and make note to the patient that there is that chance that you might get this type of acne. We heard about JAK inhibitors and herpes zoster. Again, 4-fold increase in the risk of zoster in patients receiving this class of medications. Again, in young patients, this is a concern. Finally, pregnancy. I showed you how safe biologics are in pregnancy. It's not the same case for JAK inhibitors. There is actually no data so far that tell us that this class of medications could be utilized in pregnancy. And the recommendation so far is to avoid their use and consider them contraindicated. We heard about patient preference, and this study, which Dr. Uthman led locally, so what we did is that we presented 2 case scenarios with different characteristics and attributes. Both physicians and patients filled the seats, and we analyzed the data. Dr. Badr showed you the results and that patients preferred pills. But again, he didn't point out that the highest scoring was with concerns about increased risk of malignancy, showing us that patients in our region place a lot of weight on safety compared to efficacy and convenience. So my take-home messages are biologics and non-biologics are effective for treating IBD. Biologics have the advantage of being safer and effective in special populations. Small molecules are effective, but their use has been associated with serious infection, malignancy, acne, thrombosis, and unfavorable pregnancy-related outcomes. Patients with IBD, especially in the Middle East, place significant weight on safety when choosing advanced therapy. And finally, accordingly, biologics should be used as first-line advanced therapy before proceeding with JAK inhibitors in patients with UC. Thank you very much.
What a fight. You got us into the mood of the match tonight between Al-Ahli and Nasr, which we will see later tonight. But really fantastic 2 talks. I'm sure everybody is very excited and have questions. Well, you got us more confused, but it's okay. I always thought that they probably both are the same. You just have to weigh benefits and think about what possible risk factor might that particular patient have, and then decide whether to go this way or the other way. But I really enjoyed your presentations. So we've opened the floor for discussion. Professor Ala, if you don't mind, we're already a little bit late in schedule, so make your questions relatively short and precise. And for our respectable speakers as well, please make it short answers.
Thank you both for really a wonderful debate. I mean, I've talked to better about this topic being of really pressing interest. Now, clearly, we're also limited by the insert on how to use these medications. I don't know in Saudi Arabia if it's restricted to second-line therapy or not. But one of the arguments that Mahmoud made is that once patients receive a JAK inhibitor, then they are less likely to respond to biologics. And actually, the converse is also true. So patients who receive biologics are still responsive to JAK inhibitors, but generally speaking, they require the higher dose for maintenance. We've looked at this in the pivotal clinical trial, and most of these patients will have to end up on the higher dose for both UPA and for tofacitinib. And the risk factor for both zoster, infection, and DVT, PE are also correlated with the higher dose. So we've recently published on our TOFA data in Lebanon, and the patients who received it as first-line therapy, essentially most of them ended up on the 5 milligrams twice a day as maintenance therapy. Conversely, patients who took it as a second line needed the higher dose. So again, it's a counter argument to be made, but again, we're restricted by all of the insert, I think, and the label on these medications.
It seems like you're siding with brothers. Thank you.
Kind of, yes, I would say.
Thanks, Dr. Prof. Ala, for your nice comments. Any question? Hamad, please. It's not an MDT meeting. It's we are in a master class, so
short question. Okay. We used to say IV better than IM, better than oral. When I go to the hospital, I have renal colic, biliary colic, I want an IV. And I prefer to come to the hospital every 8 weeks, so some fellows or the GI consultant or the senior come to see me. Once you give them the pills, one day they lost it, they don't take it. The follow-up is not so good. We are very busy in the clinic. At least when I see him every 8 weeks, I'm happy, and when I give him IV, he's happy. Oral he might miss, and you will lose him.
Mike, we're here, please.
There we go. So you bring up a good point. So this is why we have to personalize our choice of therapy to the patient we're seeing, right? So if you have a patient who you know very well, they're adherent, yeah, I mean, their oral or sub-Q option might be great. But if you're concerned about adherence in a patient, sometimes giving them IV, well, at least you know when the patient is not getting their medication and you would call them in. So agree 100%. You have to personalize the choice to the patient.
Yeah, and somebody, I mean, sometimes, especially if you take the pill twice a day, you take it once, you might, there's a chance that you might forget the evening dose or so, or sometimes you forget them or somewhere, but when you know that you have a specific date that you have to get there, I think you tend to be more cautious that you have the medicine with you and you take it. So your argument is quite, in my opinion, acceptable and personal choice and needs personalized discussion based on each patient. Yes, please.
We've got one question over here, Mr. Chairman.
Where?
Keep going.
Sorry.
Right to your right. Keep looking. I'm English, and we're always looking for compromise and always looking to try and broker peace. Do you think you could both be right? Because my take home is that maybe in the future we might start patients, in that hot induction. It's very hard to argue that anything's better than a JAK inhibitor. They work so quickly, so effectively. They're durable. There's no concern around albumin and CRP. So it's a very attractive induction agent. And yet maintenance, once you've got a patient who's sort of maybe hit 6 months and is in remission, then could we be using a biologic because I completely agree with concerns around pregnancy and family planning. We need drugs that are not just great in the first year of treatment, but are going to be great for 5, 10 years. These are patients who are thinking about starting families.
Yeah, I think definitely, I think Mahmoud would also agree that it goes back to the positioning is not always black and white, and you probably saw it with your talk. It's really multiple factors, the patient, disease, and the drug that you would take into account. The neat thing about small molecules, particularly JAK inhibitors, is the quick on and off. So now we're kind of even tempted to think of them as steroid replacing agent, where we can get the patient into remission sooner and then maybe maintain them on a relatively safer, more durable biologic such as VETO or IL-23 receptor blockers. And that's why sometimes we're tempted with using JAK inhibitors as first line in acute severe UC, because you know if they're going to work in the next 5-7 days, and if they don't, you know, you can still use your second line rescue therapy because by that time it's out of the system. So I think this is maybe where we should switch the way we think about, let's do biologics first, then if they fail, do JAK inhibitors. Well, maybe we can use sequential or even combo therapy up front and then take away the JAK inhibitor.
Thanks, Gareth. That's a wonderful question. I mean, it's a matter of perspective, and I mean, outside of this scientific debate, everyone's trying to prove their point. The truth is, I think the take-home messages from both of us should be a little different. It's really an eye-opener to look at all this data and just remember to take all of these things into consideration when you're counseling your patient. You need to present all of these variables. And when you choose, you tailor your therapy, not just focus on one side, which is either efficacy or safety. You have to put everything together and choose what is truly the best option for that patient without any prejudice towards one class over the other.
Just one very last comment, Dr. To both of you, actually. The parameters that we looked at, the albumin, the CRP, all these things in the setting of considering one or the other medicine that you guys were looking at, are there any differences between the two from that perspective?
I think what we know from biologics in general, the higher the inflammatory burden, the higher the drug clearance, and that's reflected by high CRP and low albumin. So I do pay attention to that even when I'm starting a patient on a biologic. So if I'm, for example, doing infliximab or adalimumab, I would be more proactive in therapeutic drug monitoring. But also when you're using the non-anti-TNF biologics, if you look at predictors of needing dose escalation, almost always albumin will show up. That low albumin is a predictor of needing dose escalation for VETO and ustekinumab.
What about for small molecule? These factors play a role?
So they definitely play a role, but because they're not biologics, they're not large molecules that are protein bound. So you're not likely, let's say, to get drug clearance, but they do play a role because they're sicker patients. But not in the way where you have more clearance with biologics.
Okay, well, thank you very much. We're running out of time
but
here.
There was just last question I wanted to ask about. I'm here. In context of...
Yeah, make it short, please.
A short question. In context of acute...
Make it only one. We're closing the session, but you stopped me, so go ahead and ask your one question, please.
Yes, just in context of the acute severe UC, when the clock is ticking and we have a very time-bound decision to make where a patient either failed treatment and the colectomy is just next door, we have a much more control on using biologic, for example. But when it comes to using the JAK oral medication, where do we see our patient where a small misstep can lead to a surgical intervention in our patient? I have a number of patients asking this question, that how confident we feel and how long we need to wait for JAK to work before we can say patients are safe to avoid the colectomy.
I think Dr. Al-Ghamdi in his session really nicely outlined the use of JAK inhibitors in acute severe UC, and he nicely showed the data from, I think it was a TRIUMPH study, where it showed that if the patient's rectal bleeding score is 0 at 7 days, that predicts that they're going to do well and going to maintain the drug. The TACOS trial had their primary outcome at day 7. So in my mind, if day 7 the patient is not responding, it's probably futile to continue JAK inhibitors at that point.
Thank you very much for all of you, and we'll see you, I think we have a break now, and then we'll see you again in the next session.
يمديك تجيبهم ولا؟
Hello everyone. Can we just ask you to stay till we have the satellite symposium before we have the break, if you don't mind? السلام عليكم. لا هو بوقف نهدة. تبغى نهدة تقول بريك بعدين في بريك. ما ادري عنها.
خلنا بريك خلاص. بريك في بريك. بريك.
هذا كله شغل ابو سعود.
الله يحفظك. شرفتنا ابو سعد الله يحفظك.
السلام عليكم.
The presentations up there.
Okay. Okay.
هنبدأ نبدأ والشباب they will join. We start and they will join. Then we're 15 minutes late. Are we ready? Is it working? Is it moving from here? The clicker.
Clicker.
Shall I try? And then we can go back. It's not okay. Still, no, it's not going back. No, okay, it's lagging behind. Okay.
السلام عليكم. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. We're trying to stick to the time, so we'll not have the program delayed. This is my pleasure to invite you to the Satellite Symposium, the first Satellite Symposium of our IBD masterclass, sponsored by Takeda. And I'm delighted to be joined by two great speakers, Prof. Mahmoud Mosali, who's a consultant gastroenterologist and inflammatory bowel disease specialist in King Abdulaziz University from Jeddah, and Dr. Tawqi Al-Amil, a consultant gastroenterologist, inflammatory bowel disease specialist from King Fahd Specialist Hospital in Dammam. They're going to take us in a journey talking about navigating this TRIDE2 and also colitis and Crohn's disease with NTView. So, Prof. Mosali, the floor is yours.
Hello. Thank you, Dr. Abdullah, for the kind introduction. I'd like to thank Takeda for inviting me to speak in their satellite symposium. And I'd like to thank you all for being here today. It's a pleasure to be in this duet with my dear friend, Dr. Tawqi Al-Amil. Together, we will try our best to take you through how NTView is a drug that is designed to effectively reach all of the targets that we recommend for the treatment of inflammatory bowel disease. So these are my disclosures, and these are Dr. Tawqi's disclosures. So the objectives, first of all, we'll go through a background, looking at the evolution of treatment goals in ulcerative colitis and Crohn's disease, touch on the natural history of the disease, and then, in detail, discuss vedolizumab efficacy. So we'll start with short-term targets, move through to intermediate and then long-term targets. Then we'll talk a bit about treatment persistence and how to prevent disease impact. And finally, we'll talk a little bit about some additional targets. So let's start with reframing some perspectives in ulcerative colitis, some misconceptions. So we always hear Crohn's disease is a progressive disease, ulcerative colitis might not be as damaging. Well, the fact is, UC is as progressive as a disease as Crohn's disease. Both diseases have similar impacts on patients' life. They have similar economic burden. Both diseases can lead to complications of different types. Surgery cures neither disease. They both require the same monitoring, treatment goals, and have very similar therapeutic armamentariums. Even the slightest activity under the microscope, so histologic activity, is associated with progression in patients with UC who are asymptomatic over the course of several months. And the more that inflammation is, the more likely that damage is to occur. The traditional teaching was that patients, for example, with ulcerative proctitis rarely progress or extend their disease. Well, in fact, accumulating data and evidence tell us that this disease can also be progressive, and what starts with proctitis can end up with pancreatitis. As I just told you, the degree of fibrosis and damage that happens with progression over time is proportional to the burden of inflammation under the microscope. So the more inflammation that is seen, the more damage can occur in fibrosis over time, which leads to complications. So those are some points that are very important to keep in mind when thinking about the way ulcerative colitis is treated. What about treatment targets? We've heard a lot about treatment targets today, but what is important to understand is that we moved away from symptom-based targets to more objective ways of measuring disease activity and more hard outcomes as endpoints of treatment, with the hope that this might change the disease course with time. So we went from focusing on just controlling the disease with the traditional clinical response, clinical remission, biomarker normalization, endoscopic healing, to thinking about how to modify the disease on the long run. So preserving and improving quality of life, preventing disease complications, and reducing the risk over time. But that all depends on our ability to introduce the right drug at the right time. So preferably in the early course of the disease, at the window of opportunity, before any damage had occurred. That gives us a higher chance of being able to prevent complications with time. Something we've learned a lot with studies that have been published in the past few years, and this figure that has been reproduced over and over, which is from the Liman Index paper. Now, we heard today both Gareth and Hiba in their talks touched on the CALM study. It's a very important landmark study that told us about the value of tight control and a treat-to-target approach when treating patients with Crohn's disease. Reaching endoscopic remission and deep remission have been associated with lack of progression over time and decreased risk of complications during the duration of follow-up. Now, this led to the standardization of treatment. Now, it's pretty much standard of practice to follow a treat-to-target approach, namely the STRIDE-2 guidelines is presently being used and recommended and endorsed by almost every single guidelines worldwide. So I'll hand over now to Dr. Turki to take us through targets of therapy and how Entyvio vedolizumab is able to reach those targets. Dr. Turki?
Thank you very much, and good afternoon. I think one of the beauties of using the STRIDE guidelines is that it gives you a clear indication on what to do and what should be your target in the short term, mid-term, and then long-term management of your patient. So we'll go through the short-term targets, starting with the ulcerative colitis data. This is a post-hoc analysis from the Gemini trial, phase 3 trial, looking at rectal bleeding score and stool frequency score. And you can see that patients with ulcerative colitis who received vedolizumab had significant improvement compared to placebo arm as early as week 2 after initiating therapy, with lower frequency of rectal bleeding and lower frequency of their stool. And in the same line of ulcerative colitis, the visible data, which we looked at subcutaneous subcutaneous vedolizumab use, visible 1 looked at ulcerative colitis data. 85% of patients who completed the induction had clinical response after the induction, the second or third IV infusion dose. So significant improvement after only the induction doses of vedolizumab. The VARSITY was a head-to-head trial, as most of you know, comparing adalimumab to vedolizumab in patients with ulcerative colitis. And analysis from the VARSITY showed you that you can see clinical response in patients with ulcerative colitis who received vedolizumab as early as week 14 in at least 2/3 of the patient population that received vedolizumab, 67% compared to 45% in those who received adalimumab. Now, shifting gears and looking at the data from Crohn's disease trials, this is from the Gemini 2 and Gemini 3. Both trials looked at patients with Crohn's disease who received vedolizumab compared to placebo. And you can see that there is a significant improvement in the abdominal pain score and the loose stool frequency score as early as week 2, week 4, and week 6. And as you would expect with most advanced agents, the data looks much better in bio-naive population compared to those who were exposed to advanced agents in the past. On the left-hand side, you see bio-naive patients. On the right-hand side, you see the overall population, including those who failed advanced agents in the past. Visible 2 was the clinical trial looking at subcutaneous vedolizumab maintenance in patients with Crohn's disease. And in this study as well, 83% of patients achieved response with vedolizumab IV induction, and over half of total symptomatic improvement was achieved within 2 weeks of treatment, so quite early in the treatment process. So by the end of the second or third dose, 82% of patients had clinical response with vedolizumab induction. This is an interesting post-hoc analysis of the visible 2 data as well, looking at the daily abdominal subscore, and they divided patients based on how severe was the abdominal pain at the initiation of the study. And on the left-hand side, you see the overall population. Having a severe pain was reflected here in the gray color. Having no pain is in the pink color. And as you can see from left to right, as time went on, the gray area shrinked, indicating that lower percentage of patients had severe pain. And this is only looking at 15 days after initiating therapy. So we saw significant improvement in symptoms in patients with Crohn's disease who were initiated on vedolizumab infusion. So if I'm seeing clinical response in both ulcerative colitis and Crohn's disease patients in the short term, what should be my intermediate target? And Dr. Farhan outlined the targets in her talk very nicely. And looking at the data from a vedolizumab study, the intermediate target is probably looking at biomarker improvement. And this is, again, a look at the VARSITY trial and the drop in fecal calprotectin after initiating vedolizumab or adalimumab in patients with moderate to severe ulcerative colitis. And you can see that as early as week 2, there was a mean drop of 1,400 milligram per kg of fecal calprotectin. And if you waited a bit longer until the end of the trial, the drop was 1,600. So significant improvement in fecal calprotectin as an important biomarker in patients with ulcerative colitis. The concentration improved as well in the visible 1 study, the subcutaneous vedolizumab maintenance in patients with ulcerative colitis. On the left-hand side, you see patients achieving biochemical remission with fecal calprotectin being less than 250. And from week 0 to week 52, more patients achieved this target of biochemical remission. In the in the pink color, the IV group, and in the darker color is the subcutaneous group, and in the gray is the placebo arm. And as time went on, more patients were in biochemical remission. On the right-hand side, you see the percentage of patients who were actually having high fecal calprotectin, and again, this percentage went down as we treated patients with vedolizumab for longer. The medication improved the inflammatory markers during induction period in patients with Crohn's disease. This is the Versify trial by Silvio Danesi and colleagues, a single-arm trial looking at objective markers of inflammation in the ileum and colon in patients with Crohn's disease, and CRP concentration went down significantly with the introduction of vedolizumab. Fecal calprotectin also went down significantly with the introduction of vedolizumab and the end of treatment as well. This is data from the Gemini 2 trial looking at the proportion of patients achieving normalization of their CRP during maintenance therapy. Significantly better improvement with vedolizumab in both doses, Q4 weekly and Q8 weekly, compared to placebo. So you expect to see normalization of the CRP with the introduction of the medication, and the longer you wait, the more patients will achieve this target with treatment. Another important intermediate target is clinical remission. So in the early phase, you want to see some response. However, the intermediate target would be remission and resolution of the symptoms for patients with IBD with therapy. So this is a Gemini 1 data, ulcerative colitis patients. More than a third of them, more than 40% of them receiving vedolizumab maintenance therapy achieved clinical remission at the end of 1 year therapy with both doses, the Q4 weekly and the Q8 weekly doses, compared to only 15% of patients receiving placebo. Similarly, the Visible 1 data looked at patients who received vedolizumab and significantly better clinical remission data with both the sub-Q and IV maintenance improvement. That positioning the right agent at the right time is critical in managing these patients. Corticosteroid-free remission and clinical remission is an important outcome we look at, and this is data from the VIDO IBD study. In this presentation, we aimed to combine clinical trials and also real-world observational study, and you can see that most patients who received vedolizumab did better in terms of remission rates compared to those who were receiving anti-TNF agents in achieving steroid-free remission and clinical remission. Back to Crohn's disease and clinical remission in patients with Crohn's disease. This is Versify data again, looking at clinical remission achieved by 1 out of 3. So 1/3 of patients who received vedolizumab achieved clinical remission at week 10 and 26, regardless of their exposure to anti-TNF in the past. So quite effective therapy, achieving clinical remission with a CDAI of less than 150. This is data from the US Victory Consortium. This is a multi-center study looking at patients receiving vedolizumab, with IBD receiving vedolizumab in many centers in the United States. And you can see that patients were more likely to achieve clinical remission if they had shorter disease duration, and they were more likely to achieve clinical remission, steroid-free remission, endoscopic remission, and other important targets. This is also a real-world data looking at the use of vedolizumab in anti-TNF naive patients with Crohn's disease. This is a European study showing that you are actually more likely to achieve clinical response and clinical remission if you waited longer for the medication, and more likely to achieve it in patients who were not exposed to advanced therapies in the past. So the long-term targets, I think for Professor Mosley as well, will discuss this. Mucosal healing, endoscopic improvement at week 4, maintenance therapy versus placebo at week 52. Is this for you, Prof. Mosley? Mahmoud? Yeah, okay. So mucosal healing rates were almost 3-fold higher with vedolizumab every 4 weeks compared to maintenance therapy with placebo at week 52 in patients with, in the Gemini 1 data, in patients with ulcerative colitis. The subcutaneous formulation resulted also in greater rates of mucosal healing at week 52 compared to placebo, 56 percent of patients receiving vedolizumab compared to 21% of patients receiving placebo. So regardless if you maintain the medication as an IV or as a sub-Q, you are more likely to maintain your remission rate and mucosal healing as time goes on. The data also showed superior endoscopic improvement when you compare vedolizumab to adalimumab at 1 year of therapy in patients who were naive to anti-TNF. On the left-hand side, you see the overall key secondary endpoints, which included endoscopic improvement. And the purple color was vedolizumab. The secondary endpoints were achieved in 40% of patients compared to 27.7% of patients receiving adalimumab. And in the treatment exposure was an important factor affecting the results. Patients who were naive to anti-TNF therapy were more likely to respond to vedolizumab compared to those who were exposed to anti-TNF therapy in the past. This is also data from the LOVE CD. Early initiation of vedolizumab in patients with Crohn's disease led to better results. The primary endpoint of combined steroid-free clinical and endoscopic remission rates were higher, 47%, compared to those who were started late in the game on vedolizumab, 16%, and similar results for endoscopic remission and endoscopic improvement. Results were much better if you start the patients on vedolizumab earlier in the course of their illness. The VERSIFY trial looked at the ileal outcomes in patients with Crohn's disease who received vedolizumab, and endoscopic remission, response, and complete mucosal healing rates were higher at week 52 in those who received vedolizumab compared to placebo. And again, you were more likely to achieve your outcome of complete remission if you start the patient before exposure to advanced agents. So if you start them when they are bio-naive compared to those who were exposed to advanced therapies in the past. This is again data from the observation study IBD consortium looking at clinical remission, steroid-free remission, and endoscopic remission. And the shorter disease duration was a favorable factor that will put you at a higher chance of achieving your remission compared to patients who had the disease for longer periods before initiating effective therapy with vedolizumab. So I'll hand it back to Professor Mosley to go over the data for long-term persistency of the medication.
Thank you, Dr. Amil. We heard about the STRIDE endpoints, short, intermediate, and long-term. And we've seen that there's so much data telling us that vedolizumab is an effective agent able to hit these targets. Beyond reaching these targets, it is important to understand whether or not the medication continues to work with time. Hence why I'm going to be telling you about persistency or durability. So starting off, this is data from VEDO-IBD, the study that Dr. Amir had alluded to. And you can see here over time how until week 52, significantly more patients who were switched to another biologic drug other than vedolizumab in the anti-TNF group than in those who received the Entyvio were more likely to lose response with time. And you can see here the separation in the curve early on in the course of the disease or the treatment and separating completely all the way to week 52. So this is a retrospective set of data presented by the Leuven group, so real-world experience of Entyvio in this cohort of IBD patients. And you can see that Entyvio is superior to adalimumab as first-line treatment in terms of persistence for patients with UC. And you can see at the bottom of the figure, again, separation between the two groups as early as the first few weeks of therapy, leading up to 120 weeks of follow-up. This is data from the EVOLVE study. And again, very similar to what we've seen in the other two studies. You can see high and significantly higher persistent rates in biologic naive UC patients treated with Entyvio versus those who are treated with anti-TNF in a real-world setting. You can see, for example, in the first few months, 82.3% of patients remained on vedolizumab versus 61.5% with those on an anti-TNF, with a statistically significant p-value. Similarly, in the next two brackets, intermediately and in the long run, significantly higher percentage of proportion of patients remained on therapy in those treated with vedolizumab compared to those treated with an anti-TNF. Again, we return to VIDO IBD. We had heard about the data in ulcerative colitis. Now we're moving to Crohn's disease. And very similar, you can see that until week 52, significantly more patients switched to another biologic drug in the anti-TNF group compared to those treated with vedolizumab, 22.4% versus 5.6%, with a statistically significant p-value. Exploris is an observational study from the US that included a very large number of patients. And in this study, you can see higher real-life persistence rates in Entyvio versus those who were treated with infliximab as first line for Crohn's disease. And there's a breakdown of a percentage of persistence with time, but you can see in the lower part at 24 months, which is what matters, the long term, there's a statistically significantly higher number remaining on vedolizumab compared to those who were treated with infliximab. Now, again, we return to Leuven and how in this, to Exploris, to Leuven, you can see here in comparison to what we saw with UC, we see that in real life, Entyvio shows higher first-line persistence for almost 3 years compared to adalimumab. Maybe the separation of the curve isn't as steep, but it remains significant. So that was talking about the term persistence or durability. Now we'll talk about prevention of disease impact. So basically changing the natural course of disease and preventing the development of complications with time. So we heard a lot about the Gemini 1 study, and here is colectomy rates from the Gemini trials over the span of 5 years in patients with ulcerative colitis. So this is Gemini 1, and you can see how patients treated with vedolizumab for both induction and maintenance compared to those who received early on placebo for induction and then switched to vedolizumab were less likely to remain without colectomy. You can see, of course, that this starts to separate and become clearly distinctive following the maintenance phase of the study. I told you about the US-based study Exploris, talking about persistence, but again, the same data set reports lower rates of hospitalization, surgery, and use of corticosteroids with Entyvio when compared to the use of infliximab in biologic-naive patients. You can see, over the span of follow-up, in the first 3 months, you can see the statistically significant difference in the following follow-up time point. So at 12 months, again, a statistically significant difference. And finally, at 24 months, about 2/3 of patients treated with infliximab were likely to develop one of these outcomes compared to less than half in patients treated with Entyvio. So a side point is that this drug has also been investigated as a therapy for another condition that is related to both Crohn's and UC, which is chronic pouchitis. And you can see that the primary endpoint of this randomized control study was met. It was a small study, but it did show efficacy efficacy of vedolizumab as a therapy for pouchitis. And the reason this is mentioned here, because this definitely improves quality of life in this subset of patients where this condition leads to poor quality with time. Now, going back to EVOLVE, and we had mentioned this study before, in Crohn's disease, it's important to note what happens in these patients with regards to surgical resections, specifically bowel resections, and you can see that this was numerically lower in patients treated with Entyvio versus those who were treated with anti-TNF in bio-naive conditions. You can see on the left side there is less exacerbation of disease in those treated with vedolizumab, so almost close to half. And on the right side, although the risk or the rate of surgery was low, it was still lower in those treated with vedolizumab compared to those treated with an anti-TNF. So one other point is that the use of this drug on the long run has been associated with lower rates of healthcare resource utilization, despite the misconception that the cost of the drug is higher, but on the long run, when you incorporate all of these factors, the expenditure is actually lower in comparison to anti-TNF agents. Now, we heard at the beginning of the talk, there's other non-formal targets that have been explored as potential outcomes in patients with ulcerative colitis and Crohn's disease as well. And I'll be talking a little bit about those as well. We heard a lot about histology today. And we heard from Dr. Turki about the VARSITY study, which we're all familiar with. You can see data from VARSITY tells us that Entyvio is superior to adalimumab in achieving histologic remission after a year of therapy, using both indices here on the left side, the Gabose index, and here the target was a grade less than 2, and the right side, the Robarts histologic index score less than or equal to 2, representing histologic remission. And this was the case for both those who were anti-TNF naive and exposed as well. A new concept that has been explored in the past 2 or 3 years is the idea of disease clearance, a terminology that means clinical remission, endoscopic improvement, and histologic improvement all at once. It seems like it's a very difficult target to reach theoretically, but if you look at the post hoc analysis from VARSITY, you can note that about a third of patients treated with Entyvio or vedolizumab were able to reach this target, compared to about half of that with patients treated with adalimumab, indicating that there is a potential to be able to reach that difficult target with this type of medications. We heard about VERDICT, which is the most anticipated study probably coming up in the next year or two, comparing 3 groups. It's a randomized trial comparing treat to symptoms and endoscopy, and treat to symptoms, endoscopy, and histology, trying to identify the ideal goal of therapy in patients with ulcerative colitis using the drug vedolizumab. Now, there was an interim analysis, results from an interim analysis released recently from VERDICT, reaching about half or 50% of recruitment, reporting that actually about 37% of patients treated with vedolizumab were able to reach the target of PRO plus endoscopy plus histology. And after 35 weeks, about 30% of patients also were able to reach that target, which is quite promising. Looking forward to the full results from the study. So in both Crohn's disease and UC, we've talked about the STRIDE-2 guidelines and the targets that are endorsed and recommended. Some other targets, so specifically transmural healing in Crohn's disease, has been investigated and looked at as a target that can be potentially used in clinical practice, although not yet one of the recommendations. It's still something to explore and consider. You can see the data from the VERSIFY study that utilized MR interrogatory to evaluate whether or not the patients reached transmural healing, in this transmural disease, of course. You can see on the left side radiologic remission at 26 weeks, and at the right side at 52 weeks. So at 52 weeks, the overall population, 43% were able to reach the target, and it was higher in those who were anti-TNF naive. Although histology is not something we usually target in Crohn's disease, it's a very difficult endpoint to even explore because the disease is patchy, it's transmural, and there's no validated scoring system. Nevertheless, in LOVE-CD, you can see that a proportion of patients treated with vedolizumab were able to reach exploratory histologic remission at 26 weeks, utilizing the scoring systems from ulcerative colitis. So my take-home messages today, myself and my colleague, Dr. Al-Amil, is that treatment targets in ulcerative colitis and Crohn's disease have moved towards more objective markers of disease activity rather than focusing on symptoms. Vedolizumab can effectively achieve short, intermediate, and long-term targets in both diseases. And finally, vedolizumab has the advantage of resulting in treatment persistence. Thank you very much.
Thanks a lot, Prof. Mosley and Dr. Turki, for this elegant and detailed comprehensive review of vedolizumab data and navigating us through STRIDE recommendation in both ulcerative colitis and Crohn's disease. We have a few minutes to receive a couple of questions. We'll start with Prof. Nahla. Can we have the mic on?
Here is working. Thank you, both speakers, for this elegant talk. Actually, Mahmoud and Turki, dose escalation in vedolizumab, really we have conflicting data. So also clinically in our daily practice, they do respond. However, more new robust data doesn't recommend that or even checking the level. I need to hear from all the experts on the stage their opinion about that.
Yeah, so I don't think we have the drug level for vedolizumab as a standard of care in measuring the data and measuring the level in managing our patients. With the availability of the multiple options and mechanisms of action, I think there is less need for such a test in managing patients. And with the subcutaneous formulation of these monoclonal antibodies, there is less variability in the drug level, and we don't need to optimize it much. So I'm not sure if Abdurrahman, you have another.
Yeah, I agree with you that the data is conflicting, although I think most of us do that in clinical practice. Real-world evidence, specifically data from the US, told us that it's probably not an effective strategy. Again, you would need better, high-quality, randomized controlled trials to really evaluate that question and tell us, for sure if that's something that we should or should not do. For myself, I think I still see a lot of patients who do respond to dose escalation.
Yeah, as well, just to add, I've been seeing patients who get benefit. They kind of like reach to a limit where I lose hope from the medication. But the moment I escalate and I gain a lot, and I think as well, since Prof. Mahmoud has already mentioned the histological remission, I remember seeing some patients who just benefited to an extent that they cleared the disease completely after dose optimization, even after failure of TNF. I think definitely having a better evidence on the long-term run would help us, but until then, we are using the real-world data to use. Dr. Hamad, your question.
Again, the same issue. You give the 3 dose and then you say, okay, when you increase the dose to every 4 weeks, do you wait until the long-term data showing us that there is still improvement after, let's say, 36 or 52? When do you decide to escalate to every 4 weeks? This is number 1. Number 2, why subcutaneous is better than IV? Why not everybody on subcutaneous?
Regarding the decision to escalate, so first of all, following induction, you have the option of giving a week 10 dose in those who don't respond adequately, and then following that, reevaluate things 4 weeks later. So I don't think there's a rule that tells us when exactly you could, following that, when exactly you should consider escalating. I think it's a clinical decision, but probably not before 14 or 16 weeks of treatment. Now, with regards to the sub-Q, I don't think it's that it's better. I think it's just as good as the IV. So for me and for many of my colleagues, the past year since the drug has been available in a subcutaneous formulation, we've been switching patients to sub-Q, and I think it's more for convenience rather than anything else. If it's as good, the non-inferior, then there's no need to stick to IV. The only disadvantage is that there's no escalation protocol for this subcut NTView so far.
Making it weekly will not, there's no data?
There's no data.
Yeah, it's off label.
Yeah, there's no data.
So if there is no further question, I would like to thank both Mosley and Dr. Turki for the elegant talk, and I would invite the moderators for the next session, Dr. Jihad Sihati and Dr. Turki Al-Amil, to take over. We're looking forward to a tandem talk about caring for IBD patients out of tertiary care centers.
Thank you, Abdurrahman. Thank you. So you've been hearing about the use of advanced agents, and most of what you heard from clinical trials is in a setting of a tertiary care practice and advanced centers. And we are excited this year to have the talk about the practice of caring for patients with IBD out of tertiary care centers. And I'm happy to have my colleague, Dr. Jihad Sihati, who is a consultant gastroenterologist at Jubail General Hospital, as my co-chair. And the two speakers, I'll introduce Dr. Ma'an Khattabi, and Dr. Jihad will introduce Dr. Al-Bashir. Dr. Ma'an Khattabi is a consultant gastroenterologist and a faculty at King Abdulaziz University School of Medicine. He also heads the gastroenterology section at the Salama Private Hospital in Jeddah, and he trained in Canada for both his internal medicine gastroenterology and did his inflammatory bowel disease advanced fellowship at Western University, a well-known center in inflammatory bowel disease. Dr. Jihad will introduce Dr. Muhammad, then we'll hear from Abu Abdulillah.
Thank you, Dr. Turki. Also, we'll have Dr. Muhammad, who is a consultant gastroenterologist at King Fahad Hospital in Al Hafoof. He is leading the IBD patients care in the Al Hafoof Hospital. Thankfully that he will have this talk today with Dr. Ma'an, inshallah.
Good evening, everyone. Thank you to the organizing committee for inviting Muhammad and I to present the IBD care in the tertiary centers. Here are our disclosures. Oops. Objectives of our talk, to talk about the importance of establishing IBD care in tertiary centers, the impact of IBD unit on patient outcome, pillars of IBD unit, advantages and disadvantages of IBD care in the non-tertiary centers, and then how to overcome challenges. As we noticed that incidence and prevalence of IBD are increasing significantly everywhere. Unfortunately, we don't have any recent data to document that in Saudi. And that's why it's very important to establish the IBD care in non-tertiary centers. And it's important because I think at some point we realized that the tertiary centers are overwhelmed, which affects the waiting time for clinic visits, endoscopy, and even imaging for patients. The travel for patients who are coming from outside of the city, for example, yesterday when I arrived from Jeddah to Riyadh, the duration of the flight was 1 hour and 30 minutes, and the car ride from the airport to here was 2 hours, which affects the patients, so cost and late arrivals to appointments, and missing scheduled of IV doses if they are late to their appointments. Difficult access to excellent care and good timing if patients are from outside of the city, if they're in the smaller city they're from, if they have any emergencies, they have to go to the nearest hospital. And in the tertiary centers, there are P&T committees, and they have algorithms for all the medications first line, and as a TNF should be as first line in most of the hospitals. And then patients have to miss work and school. I'm going to hand the microphone here to Mohammed to continue talking about the peripheral centers.
Yes, thank you, Dr. Khattabi, for an excellent demonstration about the importance of establishing good IBD care on non-tertiary centers. I will talk about the impact of IBD unit on patients' outcome. This is our peripheral center experience. Our project for IBD unit was established this year on January 2024. So we want to know about the situation before establishing this unit, then what is the current situation after the unit has been established. So as other hospital non-tertiary center, usually all IBD patients, especially those who are newly diagnosed or complicated cases, are following in general GI busy clinic, where there is no enough time to discuss with the patient different aspects of the disease and management plan. And some patients, they lost their follow-up, and they have to renew their appointment or to get a new referral, then they have to wait. And our waiting list in our center was long. For any active complaint, any symptoms or flare, patient has to go to ER, and some patient will need to go multiple visits to ER and will stay a long time in ER. Also, the rate of referral to higher center at that time was more than nowadays, especially with lack of advanced therapy and absence of colorectal surgeon in our center. What about the current situation after the unit has been established? So now we have initiated an IBD clinic, and we have time to discuss with complicated cases with them and to educate patients more about the disease. And we're informing our patients if they lost their follow-up for any reason, they can access to us through this clinic at walk-in during working days. We can receive any complaint, any symptoms from the patient by access to our clinic, either physically or virtually. We are giving our patients the extension for the clinic. They can contact us and call us at any time during working days, and by this we are able to decrease the ER visits and the load to ER. Also, we initiated a multidisciplinary team meeting to discuss the complicated cases. Any case that needs surgery have to be agreed in the meeting with the presence of colorectal surgeon, radiologist, and a nutritionist. And recently, we have agreement with our colleagues in pediatrics that no need to refer patient in the usual manner to go to screening clinic, then to general GI clinic for take around 6 months, but he can refer to us immediately to IBD clinic. And by this, we're able to decrease the rate of referral due to this well-structured unit and presence of well-qualified colorectal surgeon and multidisciplinary meeting. Just to focus on important point that was mentioned by Dr. Khattabi regarding the travel issue and some difficulties. You can see here in the right-sided picture, the distance from our area, Lahsa, to Dammam will take around 1.5 hours by car, and for the left-sided picture, from Lahsa to Riyadh will take around 3.5 hours. Just imagine how frequent patient will go and how will cost him will travel regularly outside the city to get the IBD care, IV infusion, appointment, or follow-up for surgery. And one time I meet one patient, a young female, she stopped her follow-up because she has some difficulties in going to higher center. This is one case example I want to share with you. This young lady with fistulizing Crohn's disease came to our IBD clinic as walk-in without official appointment. She complains of severe abdominal pain. She was examined bedside, then she has severe abdominal pain. We arranged CT urgently, which found large abdominal collection. Then electively, we admit the patient through this clinic. This example will tell us the impact of excellent IBD unit in patients' outcome and decrease the load to ER. So what are the pillars for IBD unit? The IBD unit is a team. and a result of collaboration of this team. Apart from gastroenterologist, the main pillars are colorectal surgeon, IBD nurse, and for sure radiologist, which is available in most of the centers, and if we have access to nutritionist, will be best. Altogether are important members for multidisciplinary team. This is the practical pathway for our IBD patient. We are seeing patient in the clinic. We refer them directly to dietitian clinic for nutritional optimization or preoperative assessment in case of need for surgery. And for those cases who need surgery, we are discussing in multidisciplinary team meeting. If agree on surgery, then he will be seen in colorectal surgery clinic. It is worthy to mention that teamwork is the key to success. And although I'm the one presenting our experience, this is team effort. And all of my colleagues, surgeons, nurses, and radiologists contributed to this effort. This is one of the educational IBD meetings that are held regularly in our region to discuss different IBD-related topics. And now we'll move to my colleague, Dr. Khattabi, to share with you his private experience.
Okay, I'm going to resume my talk with a case which is an example for one of the advantages in the private centers, the easy access and fast actions, what we can do. 37-year-old lady who was referred to me by her obstetrician. She is gravida 3 para 2, 11 weeks of gestation. She was referred to me on July 16 of this year on 20 milligrams of prednisone, which was prescribed by her obstetrician. She's known ileocolonic Crohn's disease since 2010 after she presented at that time with chronic diarrhea, abdominal pain and weight loss. No previous resections. She's biologic naive. Over the years, she received steroids, 5-ASA and azathioprine. In 2020, she had mild elevation in her liver enzymes and she decided to stop all of her medications and to follow functional medicine in Germany. She started to have worsening watery diarrhea for the last 6 months, which got worse in pregnancy up to 15 times per day, associated with abdominal pain, arthralgia. She had nocturnal pain and diarrhea too, on and off fever, no recent antibiotic use, no contact with TB patients, no recent travel, and she lost around 3 kilograms of weight in the last month. On examination, her abdomen was soft, lax, tender in the right lower quadrant, no acute abdomen. Some basic investigations were sent, and her infectious workup came back unremarkable, with calprotectin of 269. Her liver enzymes were normal, TB quantiferon and viral serology came back negative. Her CRP was 11, with the upper normal limit of 0.5. MR abdomen was ordered with oral contrast only, but it was rejected by radiology, so we ended up doing ultrasound abdomen and radiology, which showed mild wall thickening of the TI and proximal cecum with no collection seen. She visited ER 2 times in few days at that time. On July 20th, she received her first dose of ustekinumab after detailed discussion with her about the risk and benefits. And I tapered her prednisone doses, was seen again 10 days later. Diarrhea improved to 50% compared to before, and no more nocturnal bowel movement, and CRP improved by 40%. So she, from the time she presented in the first time to the time she received her first dose of IV loading Stelara, it was 4 days. Advantages of the private centers: earlier diagnosis and assessment, easier appointment bookings, availability of diagnostic tool and point of care, availability of all advanced therapies and can initiate any of them with no specific algorithm like the tertiary centers. Availability of high standard specialized staff. I'm talking about pathologists, surgeons, and dietitians, and obstetricians as well. Easy access to IV biologics same day if we need to. Easy access to admission through ER or direct to the floor. GI clinics next door to endoscopy, which allow us sometimes to, if we have UC patient with flare, We can take the patient to the endoscopy suite for a quick flex sig, evening appointments so the patient do not have to miss work. Some of the disadvantages, short time slots for each patient, lack of patient educators and IBD, IBD nurse, lack of telemedicine. Patient must be seen frequently for medication renewal approval by insurance, which can be an advantage or even, and sometimes it's a disadvantage. Difficult to get dual advanced therapies if indicated. No formal MDT rounds, which is very difficult to organize in the private sectors. Sometimes we have to wait for insurance approval longer and lack of insurance. How to solve these issues? For short time slots, IBD clinic with 30-minute slots, and that's in process, and finally I got the approval from the higher management. Lack of telemedicine. Typically I give my phone number and I ask my IBD patients to communicate with me through WhatsApp if they have any concerns. No formal MDT, but I have rapid access to my colleagues in the different departments, pathology, radiology, and even surgeon. And I do like all of these in the background, talking to each one of them. Insurance approval, sometimes it's very challenging, but what I do, I issue reports and I ask patients to submit this report to the Council of Health Insurance, and typically they get approval like within few days. Lack of insurance, I do communicate and organize with my colleagues in the Ministry of Health and Tertiary Centers to transfer these patients for advanced therapy. I would like to conclude that IBD care in the non-tertiary centers has many advantages over disadvantages. Excellent IBD care can be achieved in non-tertiary center, and it's important to engage the non-tertiary centers and activate excellent IBD clinics to offload the overwhelmed tertiary centers. Thank you.
So, thank you so much, Dr. Ma'an, and thank you so much, Dr. Mohammed, for this talk. I see it like a competition between the non-tertiary and the private sectors and for the peripheries. Now we will open the discussion for any question if you have from the audience. Yes, Dr. Iman. If you can give the mic so we can hear all of us.
Thank you so much for the excellent presentation, both of you, Dr. Ma'an and Dr. Mohammed. I have a question to Dr. Mohammed. Do you think sitting join the clinic, whether with the surgeon and as a transition clinic as well, for those patients who have been discussed in the MDT, just to involve the patient, will improve the outcome and will get improving the acceptance by the patients for the decision taken in the MDT?
Yes, thank you, Dr. Iman. When I think this patient needs surgery, I discuss with him in the clinic initially. Then we'll discuss in multidisciplinary meeting. Then we'll take the opinion from colorectal surgeon. After we agree for surgery, then he will be discussed again with surgery in the colorectal surgery clinic. After that, we'll optimize him and prepare him for surgery.
Excellent, ma'am. Excellent, Muhammad. IBD nurse, IBD coordinator. Problem in the private? I don't know in your place in Ministry of Health. This is my issue. And in Ministry of Health, the problem is you need to take care of all the things. I don't know how Turkey he do it. It's difficult. It's burden on Turkey, on me, if I do it separately. So IBD nurse, what is the solution? In private?
Yeah, so as everyone knows, the IBD nurse has a very important role in the IBD care. Unfortunately, in the private sector, it's difficult because they look at everything at budget and revenue. I'm still in discussion with the hospital. At some point, I think we can get one, but it's going to be very difficult. And the other thing is, it's difficult to find IBD nurse or willing to be an IBD nurse and just to leave everything just to work as an IBD nurse, to work in the private sector. So I think that's my point of view, but I don't know. I think it's easier maybe in the public sector.
Yeah, from our side, just you need interested nurse for IBD and hardworking. Then we talk with the administration. We want this nurse as coordinator for IBD cases only.
You succeed?
Huh?
You succeeded?
Yeah, we succeed.
Unfortunately, yes. This also.
Yeah, and I think that the experience for Dr. Al-Bashir is probably a better experience since it's a general hospital that ran things in a certain way for a very long time, and the new generation managed to change it. So I think, I think what we heard this afternoon is very positive experience from both the private sector and the community, and I think it's an inspiration for all of us to try to improve our situation, regardless of where we practice. So I'd like to thank you, the speakers, for the great presentations. Thank Dr. Jihad Al-Sayati, my colleague, for co-chairing the session. And I'd like to invite the moderators of the next session to the stage so we can try to be on time. Dr. Muhammad Khan, Dr. Abdurrahman Al-Khormi, Dr. Yasir Mir Alim. If you can please join us on the stage. Thank you.
Thank you all. Thank you so much.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to our this third session. I would like to thank all organizing committee and scientific committee of this wonderful event. I would like to welcome my co-chair, Dr. Yasir Mir Alim, Dr. Abdurrahman Al-Khormi, and Dr. Marius. So in this session, we'll have two clinical care presentations, and we'll have a scientific discussion after each clinic. So Dr. Yasir will present the first presenter.
Assalamu alaikum. The first presenter is Dr. Ahmed Al-Darmaki. He received his medical degree in 2006. He's specialized in internal medicine, and he was awarded the Oman Medical Specialty Board certificate. In 2012, Dr. Darmaki completed his adult gastroenterology fellowship at the University of Calgary in Canada, followed by an advanced fellowship in inflammatory bowel disease. He is the head of gastroenterology unit at the Royal Hospital and the faculty member of Oman Internal Medicine Residency Program. He is well versed in the diagnosis and treatment of all gastroenterological disorder. He is skilled in both diagnostic and therapeutic GI endoscopy, including management of GI bleeding, peritonitis disease, and esophageal and colonic strictures. He is the author of numerous publications and had presented researches, abstracts in international conferences, including the ECHO meeting. Dr. Ahmed Al-Darmaki, welcome, and you have the floors.
Thank you, Mr. Chairman. Assalamu alaikum wa rahmatullah. Good afternoon, everybody, and thank you for staying until this time. First of all, I would like to thank the organizing committee for this wonderful recurring symposium, which is always beneficial for us as speakers and as attendees. So my part is sort of case interactive case discussion, but probably because of some technical problems, we will not be able to do the voting, but we'll try to do it manually. So that's my disclosures. We will skip on this. During this presentation, we will talk about, I prepared 3 cases. I hope we'll have time to go over all the 3 cases, but it will be nice to get your insights about those cases. So this talk is about extraintestinal manifestations. By now you have heard some talk from my previous speakers about the therapy and about some aspects of monitoring patients with extraintestinal manifestations. They are not uncommon. You will see them quite frequently in your practice because IBD is not really restricted to the gut. It can involve the GI tract and outside the GI tract. Up to 50% of patients would have at least one extraintestinal manifestations. And those manifestations sometimes can negatively affect the patient quality of life more than IBD. So it's very important for us as gastroenterologists to be aware of them and look at the patient from 360-degree views. ECHO guideline, the latest one, categorized those extraintestinal manifestations into classical ones, associations, complications, treatment-related. All of them can be called extraintestinal manifestations. And they are due to systemic inflammation where the immune-mediated response will cause inflammation outside the gut as an extension of the gut inflammation or as an independent inflammatory events, as you can see. They share genetic predisposition. This nicely shows how the shared genetics between IBD and extraintestinal manifestations can be so multiple and complex. So for you as a practicing clinician, you would expect to see patients with IBD along with extraintestinal manifestations. At least probably half of them might be having some musculoskeletal symptoms. Mucocutaneous and ocular manifestations will be among the commonest also patient complaints. To less extent, hepatobiliary, pulmonary, vascular, cardiac, and more than 20% of patients would have 2 at least. So it's not easy to overlook. And just keep in mind that quarter of your patients might have extraintestinal manifestations before the development of their IBD. Some of the EIMs can parallel with IBD and some of them will not. And some of them will be in between, but mostly will not parallel, like PSC, uveitis, and pyoderma gangrenosum. So let's start with the cases. Our first patient is a 40-year-old female, married, having 4 kids, not smoker. She came from Sudan recently to Oman, and after that we saw her. But on history, she had long-standing history of eye redness and pain and light sensitivity. In 2018, she got a diagnosis of anterior uveitis, and she was treated with prednisolone eye drops. She developed joint pain 2 years later, and she was labeled as RA, but that diagnosis was refuted, although she already have received methotrexate, prednisolone, hydroxychloroquine. 4 years after development of uveitis, she got an abdominal pain, she developed diarrhea and urgency, and she underwent a colonoscopy, which showed patchy ulcers in the terminal ileum and colon, no biopsies, probably because of resources issues, and she had a CT scan, which showed a long circumferential thickening of the terminal ileum. So at that time, she was started on sulfasalazine and prednisolone that gave her some good response. Then sulfasalazine was stopped because she developed transaminitis, which improved after this, and she was switched to mesalazine. 6 months later, she stopped also the mesalazine, and she went without medications until she developed left eye redness again and mild discomfort. In the clinic, you will see her always tearing and trying to scratch her eyes. So the question for the audience here, and I don't have, sorry, the Slido application, but we can use the hands. What will you do for this patient? I didn't mention a diagnosis, I just mentioned some external manifestations, GI symptoms, and the patient is just in front of you now. So what you will do, anybody who will start high-dose methotrexate? Okay. Anybody would just go and repeat colonoscopy with biopsies right at the beginning? Restart mesalazine? Begin prednisolone? Refer urgently to an ophthalmologist? Excellent. So really it's about identification of the urgency, and although most of those options will be valid, but patients with uveitis or suspected uveitis, you should always think about referring to an ophthalmologist. So we've done that. Patient was seen and evaluated and started on appropriate therapy. From our side, we sent investigation. Patient had anemia, hemoglobin of 10.4, with low MCV, MCH, increased RDW, typical of iron deficiency anemia. Ferritin was 9, platelets were highish, creatinine was normal, CRP was 20, normal LFTs, and fecal calprotectin was high. MR angiography was done and showed enhancing mild circumferential wall thickening in the last 10 centimeters of terminal ileum, but normal small bowel otherwise. And colonoscopy showed ulcerations in the colon and the terminal ileum. The rectum was relatively spared, and the cecal pole was slightly also partially involved. And I'm sorry about the quality of pictures, but this patient had aphthous ulcers and friability, exudate superficial ulceration. Histopathology showed patchy inflammation suggestive of inflammatory bowel disease, no granuloma though. So what will be the next appropriate therapy to manage the IBD in this patient? She is on mesalazine by now. Would you add azathioprine? No. Anti-TNF? Okay, yes. Vedolizumab? Nobody. Ustekinumab? All right. And upadacitinib? Okay, so mostly going into anti-TNF. So this patient could not afford anti-TNF. So she was continued on mesalazine and added azathioprine. Her CRP remained high at between 30 and 50 over the follow-ups. She remained anemic. She received intravenous iron, and platelets were also high. Eye symptoms recurred twice since she was seen, and she received a course of prednisolone eye drops, oral prednisolone. So for anemia now, which is another excellent standard manifestations, would you give her oral iron? Okay. Intravenous iron? Excellent. Anybody who will give erythropoietin stimulating agents? No. Blood transfusion? No. Treat the underlying IBD and monitor? I would imagine no. So in the ECHO guideline of extranasal manifestation, they touched up on the anemia in IBD, which is quite important, I think, in our practice, whether you will give oral and IV. To be honest, in my practice, I usually use the IV. Here they say you can use the oral if it is, if the hemoglobin is more than 10 to 12, or between 10 to 12, and patient does not have an active disease. But if the patient have an active disease, or if the hemoglobin is less than 8 and patient does not have clinical symptoms requiring transfusion, then you should use intravenous iron. And the key of management is always monitoring, repeating the iron and ferritin indices in 3 to 6 months, and then repeating them every 6 to 12 months thereafter. And retreatment was recommended if ferritin drops less than 100 or hemoglobin less than 12 to 13, depending on the gender. So I think, I don't know if the panelists have any questions about this case by now?
Thank you, Dr. Ahmed. So regarding the first case, you presented that the selection of the biologic therapy, you mentioned that the patient had the external manifestation. But do you think that the disease was not controlled? So other option than anti-TNF, because it best work in external manifestation. But what if we control the disease with other biologic therapy, other of the VDU or osteokinumab or JAK inhibitors? Is it an option?
Absolutely. I think the key of extranasal manifestations is to manage the underlying IBD. However, some of the extranasal manifestations require anti-TNF specifically for the management. In this patient, there was obviously an affordability issue where we could not even start a biosimilar anti-TNF at that time because of refusal from insurance. And that's why Imuran was tried. And that, I agree, that is a really less optimal approach. And mesalazine, to be clear, is something which we don't use in Crohn's disease, but we tend to see it in our practice, especially if we get cases which are referred, and some patients are just continued on it, especially if they have colonic disease mainly.
I mean, if we choose osteokinumab, for example, do you think that is going to work for this patient?
So the only thing about uveitis is that it might not parallel to your IBD activity. So using ustekinumab is still possible. However, the caveat here that anti-TNF is approved for uveitis. So if you are treating with anti-TNF, you are actually treating one medication for two different indications. You are not just treating IBD and its extranasal manifestation. No. Anti-TNF, there are randomized clinical trials about adalimumab and data about infliximab. That's why they are approved in treatment of uveitis, and ophthalmologists are using them. Ustekinumab, vedolizumab, there's no data.
Thank you.
All right. So to touch on the ocular manifestations of IBD. Ocular manifestations of IBD are manifestations that usually does not happen alone. If you can see on the chart above that patients with ocular manifestations usually have more than one non-ocular extranasal manifestation compared to patients who don't have ocular manifestations. And patients who are female having Crohn's disease, diagnosed with Crohn's disease, older age at IBD diagnosis, and who have IBD-related surgery, they are at highest risk based on this latest study. All right, so I will skip on this literature parts just to try and go to the next case. The case basically was treated initially with azathioprine, but there was intolerance, so it was stopped. Patient had worsening of GI symptoms, and then she was approved for adalimumab biosimilar, which was started, and she had improvement in her IBD with normalization of CRP and fecal calprotectin, and no episodes of iritis or anterior uveitis since we last saw her. Let's go to the second case. So this is a 30-year-old man, married, non-smoker, does not have any past medical history, not taking NSAIDs or any prescription medications. He had intermittent episodes of hematochezia since 2014. There were few episodes, but usually he would have a sort of brisk bleeding that happens overnight. He drops hemoglobin quite significantly, and he requires transfusion. Then it stops. Sometimes it's red, sometimes dark, and or black stool, and he had significant weight loss. At that time, he was seen in a local hospital where he was scoped. He was found to have ulcerations in the sigmoid and rectum, and they were around like 1 centimeter size ulcers, but they were few. The mucosa in between was normal, terminal ileum was normal, and biopsy showed minimal increase in the lamina propria lymphocytic inflammatory cells and few lymphoid follicles with focal erosions, focal cryptitis. Ileal biopsy was normal, and the patient at that time did not receive a clear diagnosis, but he was started on mesalazine. After 1 year, patient got fed up and stopped the mesalazine, stopped follow-up, and like few months from the previous scope in 2014, the scope was repeated, and there were healing of the previous ulcers, but new ulcers happened in cecal pole, and here there was some features, or there were some features compatible with IBD according to the histopathology report. It was fine for a few years. Then in between 2018 2019, he had an admission with a brisk bleeding again, with anemia, hemoglobin drop, and at that time he required blood transfusion because hemoglobin went up to 6. OGD and colonoscopy were done abroad, and they were reported as normal except for hemorrhoids, so that was the reason which they blamed. CT enterography and later MR enterography were done, and they were normal. Another colonoscopy was done in 2019, showed multiple aphthous ulcers, more in the left side of the colon, and the histopathology was not conclusive between post-infectious and IBD. Meckel's scan was negative. This is the some of the ulcers which has been seen. You can see aphthous ulcers, typical appearance, and here a capsule endoscopy which we did because we never documented a source of bleeding in the upper GI or lower GI, and in this video and the other pictures you can see that there is a deep ulcer in the probably ileum, proximal ileum, about 1 hour after of recording in the small bowel. And based on that, he was diagnosed as Crohn's disease, and also based on the chronicity of the colonic biopsy features. So he was started on adalimumab. That was in 2021. His CRP was 12. That was elevated. Then a few months later, we reassessed him. He was fine, asymptomatic, gaining weight, CRP normalized, and repeated capsule endoscopy showed only 1 ulcer, if you can see. After this 1 ulcer, we optimized his adalimumab to every week. But he developed periorbital edema 6 months after optimizing his adalimumab dose. And the edema, I'll show you pictures, it was not really related to the timing of injection of adalimumab. He consulted ophthalmology, nothing from their side. We sent him to see a clinical immunologist who initially suspected that this might be angioedema, but this diagnosis was also proven to be not correct. And dermatologists also thought it's unlikely to be angioedema, but they put him on antihistamine, which he used only for a short period of time. Adalimumab frequency was reduced after this, thinking, is it from adalimumab or not? And then we put the patient on drug holiday for around 6 months. And if you can see the features the patient is having now for almost a year or more is swelling on the lower lip, a little bit of swelling in the upper lip, mainly in the lower lip, with cracking of the lower lip, and also swelling in the eyes. The picture on your left side, right side, sorry, is a more recent one. So it's clear that he lost a bit of weight. And this is another capsule endoscopy which was done later, which showed few ulcers. He was off therapy more than 6 months at that time. We were like discussing with him the options, and we offered him to start ustekinumab as an IBD agent. After 1 month of starting ustekinumab, he didn't have bleeding for a long time. or more, like almost a year. After 1 month of starting ustekinumab, he bled quite significantly, dropped hemoglobin to 6, required admission, he was having hypotension, and required to have an angioembolization of an arterial bleed in the small bowel. So I'll probably stop by now and see if there is any question from our panelists.
Confident you were diagnosing this patient as Crohn's disease to start with. I mean, the presentation was only just rectal bleeding. So you found the ulceration. To me, the pathology was not conclusive, but still you need, I mean, to look to the patient as a whole, clinical presentation. But it was only the bleeding. So why you did nothing, for example, of different, like vasculitis, something else?
Absolutely. So that's really a legit question. I was expecting it. So this patient had, before the, seeing the ulcers in the small bowel, we documented the presence of ulcers in the colon at several occasions. And 2 biopsies at least showed features of chronicity, despite no granuloma. So putting everything together, we looked at all the differential, and obviously we checked also for connective tissue diseases. We checked the serologies. There was nothing really. He was ANA negative, double-stranded DNA negative. He didn't have worsening of symptoms over 1 or 2 years of follow-up and management in terms of, if we're thinking about lymphoma. And we tried to do a double balloon endoscopy, but unfortunately, we could not reach those lesions, which are quite deep in the ileum. So here, it's either you will leave the patient without therapy, waiting for your pathologist to tell you that this is a patient who have Crohn's disease, or you just put everything together and start therapy. And while on adalimumab, my patient was really fine, and we could also document an improvement in his ulcers in the ileum. They went from large, deep ulcers to smaller ulcers, which was only 1 after being multiple after like 1 year of therapy with adalimumab.
So if we have any questions from the floor, please, Dr. Ala, Professor Ala. Mic there.
Microphone.
A microphone is coming, Professor Ala.
Thank you, Ahmad. Very nice and interesting case. I think this highlights also an important point, is that this idea of treating to a target that is difficult to achieve, which is complete mucosal healing in absence of all ulcerations, is not necessarily the correct strategy. This patient had improved by all parameters. His video capsule had shown 1 small residual ulcer. There was really, in my opinion, no need to increase his adalimumab. You ended up with a side effect that you probably did not need to develop in this patient, lost a very effective treatment option, and he ended up with more complications. So the target doesn't have to be complete mucosal healing in every level. I mean, this patient had improved CRP normal, he was gaining weight, his capsule had shown maybe more than 90% improvement in his lesions. Again, I think this concept maybe deserves another session altogether.
I would agree with you, Prof. Ala. That is really a very important note, and we don't really reach complete mucosal healing, unfortunately, in all of our patients, despite that we really strive to do that. However, I would pass it if it was only that small ulcer on the capsule endoscopy, but his CRP was a little highish. So it improved, then started to climb up, and it was like in the range of 12 to 20. So with high CRP, I think the way to go is to intensify therapy to bring it down, and then you can assess if there is a further improvement. But to stay like on a highish CRP with minimal ulcerations, you are just waiting for the disease to go
I didn't see that, but I thought the CRP had normalized and he was doing well.
Yeah.
There's a question.
Is there any comment or question? Yes.
Thank you for the case presentation. My question regarding the lip swelling. Is it persistent or something just disappearing with time? Because I'm thinking about the possibility of granulomatous skylitis, which could be associated with Crohn's disease as well.
Absolutely, and this is what actually what is upcoming, and this is the extranasal manifestation from this long case, is the orofacial manifestations, which we always need to keep in mind. There are many, yes, some of them are very common, like stomatitis, but some of them are rare, and you might see them, like periodontitis that can be destructive, pyostomatitis vegetans that is exclusive to ulcerative colitis, orofacial granulomatosis, which we think is the case in our patient, and oral cobblestoning. There are the orofacial granulomatosis. It has many other names. Is a rare extranasal manifestation. It is recurrent, non-tender, and this is what our patient is having. Recurrent, non-tender, almost on daily basis, but it will be worse in the morning, and then as the day goes, it will be less. Our patient does not have cobblestoning, doesn't have stomatitis, but he has cracks of lips. And the features, his features are almost similar to what has been mentioned in the literature. We didn't do the biopsy as yet, but we are waiting for the dermatologist to see him and perform that.
Are there any other questions? I would like to ask you something. You offered him a drug holiday, 6 months without adalimumab. Yeah. Really? That's correct? Did you consider at the beginning that it was a side effect of adalimumab treatment, this orofacial manifestation?
Yeah, to be honest, after sending this patient to an immunologist and dermatologist who didn't think about orofacial granulomatosis, but we didn't think about it at that time. That is actually the reason I brought up this case, that we need to look into our literature, go back and check for even the rare extranasal manifestations, and don't just pass it on as angioedema or other non-IBD related pathology.
So if it was a drug-related complication, did you consider this as class effect and not drug effect? Why didn't you try to switch him to infliximab?
So initially we didn't know what is it. So that's why the right decision we thought, because, and that was after discussion with the patient and the immunologist, to give the patient a drug holiday and see if that symptoms will improve by stopping adalimumab. The only variable in front of us at that time that we increased the dose to weekly, and the patient was on adalimumab for quite a good time, I would say at least 6 months before development of those orofacial swelling, and with that there was no problem. So we started thinking, is it because of the dose? Is it because of the drug? And anti-TNF can cause many side effects that we need to keep in mind, and patient was fine. His weight was okay at that time. His CRP was fine. So like when we stopped the medication, and even after stopping the medication, the patient continued symptomless for a while. And we know that it will come, that the patient will develop symptoms, but it was very important for me also to make really sure that it's not because of adalimumab.
How many cases you saw orofacial granulomatosis? So you give 60 milligram, is it almost the 1 milligram per kg, and for how long? Then when you start TAPR, and do you start Imuran, azathioprine immediately, or methotrexate? And for how long you will continue for orofacial granulomatosis?
So the management, obviously I've seen only one case, which is this case, so that's a disclosure.
Anybody saw from the audience? Okay.
I didn't see any hands. Okay, so the management will definitely be of multidisciplinary team discussion between us and the dermatologist. They use some modulators, including dapsone and other things. And obviously, anti-TNF is tried. I'm not sure about methotrexate part, but prednisolone, yes. Dapsone can be used, yes, in combination, but prednisolone high dose initially, and after induction, you taper it down like what we do in IBD. I would imagine this is the way. All right.
We'll move to third case.
Okay. I think, I don't know if I have time for the third case.
Yeah, we can, because
Do I have time?
we are
Excellent.
continuing discussion in between, so we'll have time from the discussion.
Excellent.
We can present the third case.
So the third case will be, inshallah, short, 30-year-old man with ulcerative colitis. This guy has symptoms of diarrhea, blood, mucus, and urgency, weight loss. Initially didn't have any external manifestations. He had two brothers with IBD, similar age. He's by now steroid dependent, multiple admissions with IBD. Flexible sigmoidoscopy was done when he was admitted with acute severe colitis. Infections were excluded. And during admission, he was on IV steroids, and he had a discussion with his gastroenterologist and surgeon. He was cared for at that time in a private hospital. He was offered biologics versus surgery, and he elected to have surgery because it's the curative way. He will not need to use medications. So he underwent ideal pouch anal anastomosis in 2021. Very nice post-op period, uneventful. He was happy, gaining weight, asymptomatic. But then he started having perianal discharge, and he started feeling that there is bubbles, air bubbles coming with his urine. So he had MR pelvis, which showed only a single intersphincteric fistula, grade 1, St. James classification, no abscesses, and 6 months later he developed lower limb extremity pain associated with the wound and surrounded by erythema. He had multiple wound cultures, and antibiotics kept coming to the emergency, and he did not improve at all. So labs were fine. His albumin was normal, a little bit of anemia. Probably we'll just skip on the questions. And this is the lesions after some time. He started having very bad ulcerative lesions, and I wouldn't know if taking biopsy from the lesion also caused that, because he had a biopsy from this lesion. So he had a quite bad course, and this happened only after his ulcerative colitis has been resected completely. So he didn't see a gastroenterologist, he saw a rheumatologist for his skin lesions, where he was, and a dermatologist obviously. So he was doing the dressing and cleaning part, and also he was started on prednisolone and azathioprine with very nice healing. Currently he's on azathioprine 100 milligrams, prednisolone 5 milligrams once a day. Because of the perianal discharge, and also because of the suspicion of colovesical fistula, he came to see me. I did a pouchoscopy on him. He had very nice pouch, normal, no ulcerations whatsoever. We reached up to the anastomosis of the ileostomy side was normal, and there was only this ulcer, small ulcer in the pouch anastomosis. Biopsy was unremarkable, and he saw a urologist who was planning a further evaluation for his possible fistula. MRI pelvis was repeated, show the same fistula in the perianal area and no features of pelvic disease activity. So back to this case. This patient is somebody who had PG after treatment of ulcerative colitis, which argues again with the fact that PG does not always correlate with the IBD activity, but also there are many other causes of PG, like hematological malignancies and rheumatological disorders. So we need always to think in broad terms and involve rheumatology, dermatology, surgeons, and ourselves to solve such cases. So a question to the panel now, given that this patient improved with steroids and he will be tapering them down, would you keep him on azathioprine, or you will go on anti-TNF or other agent to prevent PG from happening, although we know it does not really correlate with the IBD activity?
Really, I feel worried about this patient. I mean, the development of perianal fistula after the surgery makes me think of a Crohn's disease. So I have to put into consideration the diagnosis of Crohn's disease, and I will treat the patient accordingly, even for the pyoderma gangrenosum. So I think he needs aggressive management to me. Okay, for likely Crohn's disease diagnosis, not the ulcerative colitis, even the type of the surgery that was done initially is done for ulcerative colitis, but I think likely he was a Crohn's disease rather than ulcerative colitis. So I would treat him with biologic therapy definitely for the possibility of Crohn's disease and also for this pyoderma gangrenosum.
Excellent. Any other thoughts?
I would absolutely agree with my colleague, and I would probably ask for an MRE.
You would ask about?
About an MRE.
MRE, yes, absolutely. We are setting him up for MRE, which I think he did last week. I have to see that. But having a completely normal pouch, except for an anastomotic ulcer, would that be correlating with Crohn's disease?
I think Crohn's disease can present initially with just perianal fistula. We have seen many patients who was treated by the surgeon for this perianal fistula for years, and because of this refractory fistula referred to us, okay, we take history from the patient. They don't have any significant clinical symptoms, and when you do endoscopy, you will find some minor, finding. You take biopsy is also not convincing, but when you follow up this patient, they will show up as a Crohn's disease with the time. So I think this patient, the possibility of Crohn's disease is high. I will not, make it, away from the diagnosis.
Absolutely.
At all, especially the type of the fistula he developed. Probably just a complication of surgery, but I think also still a possibility of complication of a Crohn's disease. Yeah. Yes, which is not a simple, thing to ignore.
Yeah, so enterovesical fistula was not proven as of yet. Bubbles of areas, which is still under workup. But yes, that is a possibility. Although he doesn't have luminal disease, you would imagine that there is a luminal disease, right? If there is, and then enterovesical fistula post-surgery also can be surgical complication. So the importance of this case as well is to make sure that you are having a proper multidisciplinary rather than one-man show, and keep monitoring the patient. Some might argue that you might over-treat him if you are giving him an advanced therapy for really a lack of diagnosis. The fistula which he had was a simple fistula, class 1, St. James, and it's not the typical fistula which you would see with Crohn's disease that's complex. It might be the beginning, you are right. So he will need very close follow-up, and the thing which might complicate his care that those patients, some patients are paying for their medications. So going and giving him very expensive medication for no solid evidence is also something which we need to take care of.
Dr. Ahmed, you're right. We are we can find few patients that turned off from diagnosis of ulcerative colitis to Crohn's disease, especially lately after we removed the colon or brought to total colectomy with IBBA. So, and then like this patient that you presented, that then the patient developed a fistula, and then he had an activity of the disease, and that's why the EIM is continuing the pyoderma gangrenosum. So, in these cases, usually we have to be aggressive for the medical therapy. So, as you mentioned, that continuation of other therapy alone is not an option.
Yes.
So maybe she needs an anti-TNF and to help,
Sure.
and also the opinion of the surgery, because she developed a complication now
Yeah.
of the intervesical fistula.
And I saw him so far once, so most of that history is, and even his diaphragm started earlier. But we are planning to closely monitor this patient, and we'll have low threshold to start him on biological therapy, definitely, if there is any progression or if there is any signs of increase in the fistula or non-healing of the fistula. Now, the surgeon is seeing him for that fistula, and if it is something which is resectable, low fistula, that's they can treat, is fine. Otherwise, yes, he will need biological therapy for sure.
Dr. Ahmad?
Whenever we have a case like that, we always review vesico-ureteric fistula. You need to review the colectomy removed. If there is any granuloma, it was a mucosal disease or not. And if there is a fistula, MRE enterography should be done earlier. Any review of the colectomy?
We did review the colectomy, and that was a typical features of UC. There was no indication that this is Crohn's disease, which also makes it difficult because you are having the whole colon in front of you, part of small bowel, and nothing is saying that there is Crohn's disease. Yeah.
I think with that we'll come to the end of this clinical case presentations. We'll move to our second presenter. Thank you, Dr. Ahmed, for fantastic and really amazing, challenging cases.
So we will continue with the next case presentation concerning anti-TNF complications. I would like to welcome Dr. Mohammed Shihab. Dr. Mohammed Shihab received his medical degree from the University College of Cork in Ireland. He continued his internal medicine residency at the University of Toronto, his gastroenterology fellowship and advanced training at McGill University in Canada. He is right now a consultant gastroenterologist at Haya Al Habib GI Center at Kuwait. He is also the Secretary General of the Kuwait Gastroenterology Association and the IBD Fellowship Research Supervisor at McGill University. Dr. Shihab, we're looking for your presentation.
Thank you. Thank you for the organizing committee for inviting me. Always happy to be here in Riyadh and in Jeddah. I have a challenging task now to keep you awake. I think that's one of the last sessions. I'll try to make the case more interactive, so I'll ask the audience and the panel, and it shouldn't be long, inshallah. So, talk about the patient. So this is a 63-year-old female who has a past medical history of hypertension, hyperlipidemia. She's in telmisartan, atorvastatin. She doesn't have any family history of IBD or colon cancer. She's married with kids. She's a school teacher, used to be a school teacher, non-smoker. Regarding her IBD history, so she was diagnosed with ileocecal Crohn's disease in 2009 at the age of 48. Colonoscopy at that time showed moderate ileitis. She did a CT also, which showed 20 centimeter ileitis, no fistula or structure. However, this was all retrieved from an old report. We have no more details. Initially, she was started in budesonide and was maintained on azathioprine from 2009 until 2013. In 2013, she flared with abdominal pain, diarrhea, not feeling well. So her gastroenterologist did a colonoscopy, showed severe ileitis at that time. Then they decided to start adalimumab. Azathioprine was stopped, and she was starting adalimumab in 2013. So a few weeks later, she was feeling well, no abdominal pain, no diarrhea, and clinical remission. Her lab was normal. However, no follow-up colonoscopy or imaging was done. And from 2013 until 2020, she was only taking adalimumab with no imaging. She said she had some tests like in a year, every year. I'm not sure if she did any tests, but she said she had no issues. She didn't have abdominal pain or diarrhea. She was on adalimumab at that, and sometime during these 7 years, she got escalated to weekly adalimumab. She said because they had a flare or something, but the history is not very clear. But anyway, she was on adalimumab for 7 years and was escalated in the middle, like maybe 3 or 4 years later, and 1 weekly, and then she continued to be on adalimumab from 2013 until 2020 with no issues. So in 2020, she came to see me with abdominal pain, right iliac fossa pain, watery diarrhea, not feeling well. Her CRP was 15, fecal calpro 353. Her other labs were normal, stool workup was negative. Colonoscopy showed severe ileitis with large cecal ulcer. Her CSCD score was 16. Gastroscopy was normal. So her adalimumab level was 12. Sorry. No antibodies. MRE showed 15 centimeter ileitis with mild luminal narrowing. MR pelvis was normal. So just before we answer, she is like a patient who failed azathioprine, then been on adalimumab for 7 years, then she was flaring on adalimumab when ADAC would love. So what's next step? Is it surgery or medical therapy? Just to touch on some literature. So we have most of you know, like the LYRIC trial, which is a multi-center prospective trial of 28 centers in the UK and Netherlands. We took patients who get ileocecal resection, less than 40 centimeters disease, versus those who were taken infliximab, who took infliximab, anti-Upirian steroid refractory terminal ileal disease. So the primary outcome was quality of life, IBD quality of life, and the secondary outcome was general health being quality of life. So at 1 year, the study did not reach the difference in the first year in the IBD quality of life. However, the secondary outcome was reached in general health being, means absence of school, absence of work, going to social activity was better in those who had surgery ileocecal resection than those on infliximab. And at crossover at 4 years, those patients who started having surgery and then needed infliximab after 4 years, 25% patient needed infliximab after 4 years, whereas those who had infliximab initially, more than 33% of those needed surgery later in the year. So from this study, we can say maybe surgery is a good option or maybe a better option than anti-TNF. We also have another retrospective data. This is a nationwide Danish retrospective data. Also looked at patients who had anti-TNF or ileocecal resection within 12 months of diagnosis. And the composite outcome was Crohn's disease-related hospitalization, surgery, steroid, or perianal disease, more than 1,000, like 1,279 patients. And you can see the two arms, kind of like 45% had surgery, 54 had anti-TNF therapy. And the composite outcome was 33% lower in those who had surgery versus those who had anti-TNF. And at 5 years, you can see those patients who had surgery at 5 years, they were not on any treatment. So from this study, we can say maybe surgery is also like a good option in patients who have limited ileal disease. How about medical therapy, those who are in anti-TNF? Sorry, just one slide behind. Okay. So this is a systematic review, just combining all studies on patients who were failed anti-TNF and was getting another therapy like ustekinumab, vedolizumab, or anti-TNF. And here, like if you can see the second one, the patient was received Crohn's disease response rate who did not have TDM. So response rate was assessed by HBI score or CDI score or endoscopic response. So the response rate differ between all these studies. But you can see if you switch from anti-TNF and ustekinumab, maybe the response rate is around 56%. If you switch from anti-TNF to vedolizumab, it's a bit less, 53%. We know that vedo is not maybe as a good second-line option in Crohn's disease. And if you switch from anti-TNF to anti-TNF, is around 54%. So you have, now, what would you do next? So you have a patient who is on adalimumab for 7 years, levels are 12, and no antibodies, and limited disease. Just to tell you, the normal levels, recommended ACG levels, more than 7.5. There is also some data, maybe Australian suggests 8 to 12 may be associated with mucosal healing for non-fistulizing disease. For fistulizing disease, maybe you aim for higher levels. So would you increase adalimumab frequency or dose? Would you switch to infliximab? Would you switch to vedo? Would you switch to ustekinumab? Would you do surgery or any other options? Anyone wants to answer? Yes.
What I usually do for those patients with limited inflammatory ileal disease to open the discussion for surgery from the start. Usually in our culture, they are reluctant to go for surgery from the start. So I'll try one anti-TNF and then the surgery will be the second option.
I think that's a good thing. Now we are more after the RECCE trial, we're more trying to convince patients, even surgeons, our colorectal surgeons in Kuwait, they're not convinced to do, they used to do surgery for obstructive disease, structural disease, but now we're trying to convince our colorectal surgery by knowing the literature that even with inflammatory disease, surgery is also a good option, and we've been sending those patients. Yes, Prof.
Mohammed, I think it's important to point out that the LYRIC study was an early intervention in patients who had not received therapy. So
Correct.
It's very different than your patient. So the fact that it works pretty well as a first-line treatment cannot be translated to, good results in someone who's failed anti-TNF. Now, of course, surgery is a good option, but the chance of post-operative recurrence is also something that needs to be considered, and you cannot really translate the LYRIC data on this particular patient.
Absolutely, I agree with you. But do you think now, since she's already failed one therapy, maybe this is more of a reason to do, especially she doesn't have high-risk features, not fistulizing disease, first surgery?
I had to step out, so I missed part of the presentation. But I, generally speaking, I think the discussion, as Iman mentioned, should be done. But I think, generally speaking, I don't send patients to surgery if they have inflammatory ileal disease and they've only failed one agent.
What would you choose for that?
I think upadacitinib is an option, for example, for me. UPA would be a good option. Ustekinumab, potentially, IL-23 inhibitors are options. Depends
She's
on
63. You still with the UPA?
I think they're safe.
Okay.
They're these agents, well, except for the JAK inhibitors. But I mean, I've used JAK inhibitors in older patients still.
Yes, Dr. Ahmad.
I think Shihab, number 2, 3, 4 is good. So it's switched to infliximab with immunomodulator.
But you have adequate levels. This is kind of mechanistic failure. You have adequate levels.
Okay, so we do. And the question to you is, I thought you said 20 centimeter inflammation with no narrowing. So what is the limitation for resection? How many centimeter? Do you go up to 75?
If you go with, I know this doesn't we go with the LYRIC, it was less than 40 centimeters.
Less than 40.
I think I would choose a second mechanistic form of medication. In this case, ustekinumab probably would be equivalent. Don't forget that surgery in itself, even though if you look at from the Crohn's perspective itself, but there is a risk of anesthesia, there is a risk of post-operative possible complications. The age is a factor here. So I would go with medical therapy rather than surgical therapy. If she fails, then that's another.
Okay.
I think it's quite clear that we have a mechanistic failure of the drug. Okay, so there's a completely different pathway of inflammation, so we have to switch off anti-TNF. It's probably inflammatory it's an obvious inflammation according to endoscopy, but we have a patient with a long-standing Crohn's disease history. In the last 7 years, he just performed did adalimumab and nothing else. Yes. So I'm probably a little bit worried about, though it's not obvious, about the level of fibrosis, if there's any fibrosis at this short segment of the TI.
Yeah, but no in
Yes,
yeah.
no narrowing, no symptoms, but just it's a little bit provocative. My comment is a little bit provocative.
Yes. Okay. Yes, Doctor. Any other comments before we move? Mike.
Increasing the adalimumab level, adalimumab to more than this is not appropriate, as the patient has a mechanistic failure. So switching to infliximab also is not good, and you don't want more complication for this patient. BDU is not good working after failing anti-TNF according to the Gemini study. So I think the best option is going to be either JAK inhibitors, upadacitinib, or interleukins, osteoconimab, or risaconimab also is the option. I think surgery...
But remember, this is 2001 kind of thing.
Sorry?
Yeah. 2001, we didn't have...
yeah, sure. I mean, Opada or osteoconimab itself...
2021, sorry.
Okay, so osteoconimab, then. So the surgery, I think for this time, the patient still have a chance to try another biologic therapy.
Okay. So,
before, that's why choosing the second biologic therapy is good options.
Okay.
Give her the chance.
So
let me just comment one. I think I agree with Yasser with regard to the choosing. I mean, among these options, I can see only two options valid, which is the ustekinumab and the surgery. The vedolizumab, as Yasser said, is not the best option after failure of the anti-TNF. But when you tell the patient that I'm gonna send you to one option, which is the surgery, the next question will be this curing me? You will not see me again. So you will tell him, no, I need to monitor you, and there is good chance that you will need also this therapy again. So the answer immediately, no, try this therapy before the surgery.
Yes, correct, but I would explain to her like the risk of recurrence, like high risk of recurrence, low risk of recurrence. So she doesn't have fistulizing disease, she's not a smoker, no previous surgery. So risk of recurrence a bit low on this kind of, if we want to discuss surgery option. For those who have high risk, I will explain to you high risk of recurrence, and then treatment may be differ. Anyway, so moving to this patient, so she discussed the option, so we agreed on ustekinumab. So she received ustekinumab 6 milligram per kilogram IV, followed by 90 sub-Q every 8 weeks. Week 8, she was in clinical remission, no pain, no diarrhea. Week 12, CRP 7, stool fecal cal 167. Later, after 10 months of starting ustekinumab, repeat colonoscopy showed moderate active disease in the ileum with CIS-CD score of 7. So from 16, she comes back to 7, but still, if you go by our target, we plan for CIS-CD of less than 3. So just maybe we don't have this. So just 1 second. So what would you do next before just going to this? So do we have evidence? So we have from the Unity 1 study that there is an exposure response. We know the patient who had higher levels were associated with better clinical and endoscopic response. We have cohort data, retrospective data from Chicago, the Rubin group, that those patients who were escalated to every 4 weeks did better in terms of clinical, like HBI score, and endoscopic improvement and healing. So if you have this patient, so she's in clinical remission, biochemically she's good, but she still have active disease, what would you do next? Escalate to every 4 weeks, do nothing, switch to another biologic, or maybe small molecules, but we didn't have it back then, or surgery? No. But Stride told you this is not your, it didn't reach target yet.
achieving an SES-CD of less or equal than 3 in patients who get biologics is achievable in 20 to 30% of patients. So by that token, you're going to change therapy in essentially 70% of patients. And that's not true, as the Stardust trial have shown, and other retrospective studies have shown. A 50% improvement in SES-CD is associated with improved outcome, reduced risk of surgery, hospitalization, etc. I have a lot of patients who just dropped 50 or 60% and who've been years out without having one single complication. No surgery, no hospitalization, no steroid use, etc. I think this is something that you could build on. Potentially you could escalate to every 4 weeks, but I don't think necessarily one should jump the gun on the lack of improvement. Partial healing is also a good endpoint.
I agree, it's like not easy to reach SES-CD less than 3, but we have also evidence that those kind of patients, the risk of flare and complication is higher than those with less than 3. So you can argue both ways. We have, yes?
How about trying increasing to every, giving a sort of, no, just give a sort of an extra dose or so.
Reinduction, you mean?
Yeah, there's evidence that some of these patients you can capture a better response. So I would go maybe with the next dose, I would go with IV and give it Q4 maybe once or twice, and then look at the markers, biochemical markers, see if you get a response. Then that will tell you probably that the patient will do better on every 4 weeks.
So we have nothing. We have reinduction. Any other?
I would accelerate your regimen than to perform a reinjection.
Sorry?
I would accelerate the regimen to 4 weeks to escalate the regimen than to reinduct to make again intravenous ustekinumab.
Yeah. Maybe
That's
like
my
if
point.
you reach Q4, then you have no other option. Maybe you do reinduction.
Dr. Shahab, I guess it's important also to know the detailed finding of the colonoscopy
Yes,
in the
I
iliac.
agree.
Is it large ulcers that I'll be worried about? Because the number, we don't know the parameters.
Yes, I agree, because we don't have the pictures. Mainly it's ileal disease.
But is it large ulcers? What is the parameters exactly for this score?
Yeah, so like medium, maybe medium to large, not very large ulcers. Yeah. But not like small abscess ulcers.
Okay. But do you think there is a role here for the drug level?
Sorry, I don't know. Where is the speaker?
In the panel. So you think is there a role for the drug level here?
Rule for, sorry, what?
Drug level ustekinumab.
Drug level, yeah, that's a good question. So we have mainly retrospective data. We do it in Kuwait. I think Badr, he did it also. Like there is an association between, and this is really replicated, that levels, like higher levels of ustekinumab, usually above like 4 associated with good response. But I don't think we have enough data or randomized controlled trials to associate with that. And usually what with non-anti-TNF, I usually don't do TDM. Usually I just ustekinumab, I just escalate the dose. Not sure what do you think? Do you do levels of ustekinumab or you just escalate? Do you escalate ustekinumab or you do levels? Do you do ustekinumab levels?
No, we cannot do levels. We cannot measure the levels. I know that it's not very clearly defined cutoff levels of trough levels for ustekinumab.
I think what Dr. Yusuf mentioned, another shot of IV dosing. But if there is any difference between 6 and 4, we are talking about cost. 6 is as good as 4?
Well, we don't have RCTs. It's mainly like cohort studies. I don't know you can do this, but I usually do 4 because we have more like observational data on Q4 weekly.
Talking about cost, 6 as 4, is it? 6 weeks as 4 when you escalate?
I think Dr. Mohammed has a valid point, but as Mohammed said, we don't have RCTs, randomized controlled trial, to support that 4 week will give us more boost or more response.
Okay.
Okay, when you...
Let's move. Yeah, can I have a comment as well? I think there is two...
Any comment?
No. So we can continue.
Okay, we'll continue. So we asked, so this will move on. So it was escalated to every 4 weekly. continued to be in clinical remission. Her labs after 3 months, CRP is 5, fecal cal 143. So this is 11 months later after escalation, so 1 year later. Repeat colonoscopy, MRE showed 9 centimeter ileitis with mild lumen narrowing. Colonoscopy showed low rectal mass. Ileum, same moderate active ileitis, same moderate to large ulcers. Same as previous colonoscopy, and now we have a low rectal mass. So biopsies showed moderately differentiated adenocarcinoma. Staging, there is local invasion. So reviewed the last colonoscopy, because I don't want to get sued about this. So videos, the rectum was completely normal. There is no polyps, retroflexion. The last two, like one was done 12 months ago and one was done 12 months ago. There was nothing in the rectum. There was no inflammation. They didn't have any proctitis. The prep was excellent at that time. So this is it because of the sticknumab or because this is just like an association? There's no causation, we cannot tell. But what do we know so far? So do we know any so far about IL-23s and cancer risk? So this is a recent AGA updated guideline. So the current evidence does not show any increased risk of malignancy in patient IBD. So Vido, sticknumab, Riza, Miri, ozanimide, all there is no increased risk. However, we don't have long-term data, this kind of newer medication, and also no data in combining biologics and molecules and cancer. If we go to the AGA also, like they say currently, same thing. We don't have an increased risk. However, we don't have long-term data. So as we know, this is also from the recent AGA, like we know thiopurine is associated with lymphoproliferative disorders and also with non-small cell skin cancer, cervical cancer. Anti-TNF antagonist associated with lymphoma, especially if given with immunomodulator. Vido and sticknumab appear to be safe. JAK can cause most cancers except for non-melanoma skin cancer. Methotrexate can cause non-melanoma small cancers. So back to the patient. So sticknumab was held. She was seen by the oncology team. She had a very low rectal cancer. So she received first surgery followed by anterior peritoneal resection. So she ended up with a colostomy, so she's in a stoma, and then she received chemotherapy. However, ileal disease, unfortunately, like the surgeon did not take that ileal disease at the same time, so it was left untreated. So post-op, as I mentioned, received adjuvant chemotherapy. During her treatment of cancer, like for the 9 months, she was in clinical remission from her IBD perspective. She was not feeling, she was feeling well. Did not have any symptoms. However, 4 weeks after stopping her chemotherapy, so just like 4 weeks, 1 month after stopping her chemotherapy, she started to having abdominal pain and diarrhea. So extensive stool workup, including C. diff, all the pathogens were negative. Her fecal calpro 345, CRP 17, albumin 38. Colonoscopy through the colostomy, same previous ileal disease. That Dr. Ala doesn't want to touch, but the same disease is not going away. But she's symptomatic. MRE, same finding as previous, but maybe smaller, like ileitis, 8 centimeter ileitis, no fibrosis. So how do we treat patients who have IBD and active or recent cancer? We have limited data. Hello? Yes. Yes.
Yes. One issue that I wanted to raise because of the long history of the disease, and this is something we should always be careful about. Again, since 2001, and now we're talking about 2021 or so.
2009, yeah.
Almost 20 years of disease as well. I think you have to keep malignancy, not the one in the rectum, but I'm talking about the alveolar disease itself. So I'm really surprised since she went into surgery, why was that part was not resected. I would be a little bit more even concerned now that she had a rectal cancer, that even that segment of the ileum,
you mean?
The terminal ileum,
Agree.
might harbor,
We were very upset. Like the surgeon, I don't know, maybe they did not feel they wanted. Maybe that was like a difficult surgery or something. They didn't want to touch the ileal disease. It was much easier if they had like both resected, and then we will be happy. But they did not. So we have like limited data. This is a retrospective data, multi-center data, talking about the safety of immunosuppressant therapy versus anti-TNF therapy versus non-anti-TNF therapy in patients who had cancer less than 5 years. And this, you can see the Kaplan-Meier curve, and did not show any difference in those patients who had either anti-TNF or ustekinumab or an immunosuppressant therapy. So kind of from this one, the AGA concluded, you can see this is the recent AGA update, a bit of lag on my screen. So you can, sorry. Why it's not, okay. So it's not coming to my screen. Okay, so you can see like they stop, if a patient has lymphoma, you stop thioperins, anti-TNF you consider alternative therapy. If the patient has lymphoma, you're talking about. But however, anti-integrins, IL-23s, there is no change, you can continue therapy. JAK, if they say you can continue therapy. Other hematological disorders, you can continue, you can say thioperins consider alternative therapy, but however, anti-TNF, anti-integrins, IL-23s, JAKs, so on, they all say no change. But all you can see those all based on limited data. Melanoma, same thing, anti-TNF you stop, anti-TNF thioperin you stop, however, other classes you don't change therapy. We go to thioperin, non-melanoma skin cancer, stop thioperin, no change in other medication. Solid organ tumors, interestingly, also thioperin, consider other therapy, however, you don't change, you continue therapy in other all classes, but this is based on limited data, and I'm not sure if I agree with this or what. What do you think, the panel? Would you like patients who had active or recent solid organ tumor, would you continue JAKs or anti-TNFs? I know we don't have data, but what do you think of these recent recommendations?
Here's a difficult thing to call. I mean, my question to you, do you think that the cancer that this patient have is due to the anti-TNF or the ustekinumab? Or due to the disease?
We don't know, because we can't, like they say, is it anti-TNF? Is it ustekinumab? Because they have long duration of disease, but this was not colonic disease. We know like fistulizing disease can cause maybe squamous cancer, but he didn't have proctitis or any active colonic disease. But maybe just because having long disease, or maybe quiescent disease, or maybe like, I don't know why she had rectal cancer. But that's why I presented this case. It's not something common, very uncommon.
Mohammed, why do you think she got the right? I mean, it's hard to miss a lesion in the rectum. Let's say a year before, it's hard to miss even a flat lesion. I mean, I understand post-colonoscopy colorectal cancer happens in patients, but you always say it doesn't happen to me, it happens with other people. Yes. And like you said, it was an excellent prep, the examination was done by an expert endoscopist. Where did this cancer come from? Because if you go to the Lucent study, Lucent trial, the MIRI data, there were 3 patients in the MIRI arm that developed colorectal cancer.
What do you think? What's your theory?
Now, I don't know, because I asked Peter Irving this, and he said, well, you know, people don't do good examination, and that's probably why. But these were centralized reading.
Yes.
On all of
those
them.
patients, we look at the video retroflexion, there's
So
and high definition scope.
I don't know. I mean, I think your case is compelling in a way that maybe somehow this is related. I mean, we say the answer is no, the reviews say it's no, but it's probably so uncommon that you're not going to pick it up. But it makes me wonder, because I've said, well, okay, maybe that's the explanation. But now that you give this case, you particularly, and you say, okay, it's excellent, and rectal cancer, it's like, oh my God, this is, I mean, and then you're talking about a cancer in a 1-year period that ended up being invasive and requiring an AP resection.
If there is something genetic with this.
But usually that doesn't happen in the rectum.
Yes, I absolutely agree.
I mean, I understand the rapidly growing, you know, flat sessile lesions or in the right colon, but in the rectum to have a, I don't know. I think you're raising a good point here.
Yeah. Okay, so let's just move on for the sake of time. So patient, like AGA recommended not to do nothing. Like ECHO, they said you can continue anti-TNF therapy, patient with current or recent cancer, but decision has to be based case by case, because there is no good data, we don't have long-term data. Overall, like in the second statement, they say there is no, we don't have prior cancer, do not have any history of like ustekinumab, vedolizumab appear to be safe. We don't have good data that they've been associated with cancer. So back to the patient. So So surgeons, and I contact the surgeons again now post, like, can you go now do an ileal section, please? Because we don't want to, and they said that they don't want to do anything. They said, because now we have adhesions, it just have like a recent surgery, it will be a mess. We don't want to touch the abdomen. So back to us. So discussed with her oncologist and with the patient. So the patient said, no biologics. Even the oncologist said, okay, she will not take biologics, and maybe if you were your patient, you will be like feeling the same, maybe why we got this cancer. So she received budesonide, like induction, then followed by methotrexate, which was methotrexate 25 milligrams sub-Q weekly with folic acid. She was in a clinical remission by week 8. At 4 months, her hemoglobin like 11.1, similar to her baseline. LFT is
just
normal.
1 minute to conclude.
Okay, CRP normal, fecal cal 203. At 9 months later, same previous ileal disease, but she's in clinical remission on methotrexate. So this is the last question to the audience, like what do you offer her now? Start Vido, restart ustekinumab, steroid, immunomodulator, surgery, or novel IL-23's RIZA, or others?
Yeah.
Clinical remission? Yeah. So needs what? What treatment? What, sorry? Leave her alone? Methotrexate? Okay.
There's really no harm in giving him vedolizumab. I mean, the chance that
They
he
do?
will respond. Yeah, there's no
After-
harm. I mean, from a safety standpoint, it's safe, even if she has.
But why we think Vedo is safer than the other?
It's safer because I think there is no signal at all. She's already received ustekinumab.
Yeah.
Immunomodulator.
But
is
she had
not-
GI cancer, you know. I know
Yeah,
Vedo is
exactly. Exactly. So I wouldn't. I think vedolizumab is
Okay.
not an unreasonable option.
I think.
Yeah, just.
Yeah.
Okay. Okay. You mean RIZA? Okay.
I think this patient has aggressive disease, and Vido is against selective, and there is no, and one of the safest medication, even in pregnancy or active infection. So I will keep it in at least in service biologic therapy, which is the Vido. I mean, there is no harm to prevent further complication or course of disease. Yeah, but because of her current scenario, this patient in chemotherapy and she had a cancer. So what options is left for us is only the safest biologic therapy, which is the Vido.
So we have nothing to do, and Vedo, IL-23s, any other options?
I think mirikizumab and risankizumab, according to the latest ECO guidelines, may be an option now.
Yeah, yeah, RIZA like also maybe an option, but also we don't have long-term data with RIZA. I call the surgeon, but another surgeon. Huh? Okay.
Unfortunately, we have to stop here. So thanks all the
And that's
speaker,
what-
and also thanks for you for active interaction. And we'll go for the next session. Thank you.
We have a break for 20 minutes, and then we'll come back for a symposium by Hikmah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone for our satellite symposium for Al-Hikma company. I would like first to thank them for giving me the opportunity to be with you tonight. There is just only two announcements. I just want to mention it. Someone forgot his earbuds somewhere here. So if there is anyone, I will keep them with the organizers to take them. The other versions, I mean, Prof. Mahmoud Mosley been introduced since morning as an associate professor. He's a full professor for the last 2 years, and welcome him again for the stage. He will talk about the Remsima sub-Q, the upgraded version of Fliximab. Prof. Mahmoud, the stage is yours.
Good evening. Thank you, Dr. Uthman, for the kind introduction, and I'd like to thank Al-Hikma for inviting me to be part of the satellite symposium. And I do apologize that you have to hear me speak one more time tonight, but I promise you it's the last one. So the title of my talk is basically Remsima subcut or subcutaneous version, the upgraded version of Infliximab. So these are my disclosures, and my objectives that I hope to cover in this talk today is, number one, discuss the subcutaneous version of Infliximab, Remsima, with a brief discussion or illustration of efficacy and safety data from clinical trials, a touch on real-world experience, outline the evidence behind early and late switching from IV Infliximab to subcutaneous Infliximab, and elaborate on positioning as a therapy for UC and Crohn's disease. So the drug development program and clinical trials for biosimilars, as we all know, from a regulatory perspective, differs in terms of guidelines from originator biologics. It's more of an inverted pathway that I will take you through as I illustrate the studies for Remsima. So this is a summary of both EU registrational studies in green and US registrational studies in blue. So as you can see on the left side, so we have phase 1 in healthy subjects, and then we have phase 1 in patients with UC and Crohn's, and then we have a phase 3 study that was in rheumatoid. For US registrational studies, we have a phase 3 study in UC and Crohn's, which I will be describing in detail, which is the Liberty program. So let's start first with study number 1.6, which is randomized open-label parallel group phase 1 study to evaluate the pharmacokinetics, non-inferiority, efficacy, and safety of CTP13 subcut versus CTP13 IV. So this is the study design. As you can see, it starts off with an induction period or loading dose of CTP13 IV. So do 2 doses at weeks 0 and 2. Patients are randomized in a 1-to-1 fashion. So either responders, obviously, either to CTP13 subcut, and then also the other arm gets CTP13 IV. Then, following this, there is an option at week 22 to consider escalation of therapy. Now, these are the key eligibility criteria for UC and for Crohn's disease displayed in the bottom. So let's go through the results. So non-inferiority in terms of trough level for both formulations at weeks 22, which is the primary endpoint of the study. So the pre-mean dose concentration in the IV arm increased to a similar level as the subcutaneous arm post-switch at week 30 and remained consistent through week 54, as you can see in the graph on the right. So 9.1% and 12.3% of patients in the subcutaneous and IV arms respectively had at least one escalated subcut dose from 120 to 240 on or after week 30, which was allowed. So moving on to the serum concentration at steady state. So between week 22 and 30, you could see the fluctuation yet stable average in the steady state level for the subcutaneous formula in green compared to the IV, which drops gradually with time following the IV induction dose. Now, moving on to the clinical outcomes of the study, so clinical response and remission as measured by CDAI in the Crohn's disease population. So we have both CDAI response and clinical remission defined by CDAI less than 150. And you can see the comparison between the green, which is the subcutaneous formulation, and the blue, which is the IV formulation, and the figures are more or less the same or overlap in most parameters at different time points, obviously. What about ulcerative colitis? Very similar picture. You can see that the figures almost look the same with a few variations depending on the time point, but more or less they all are following the same curve, both for clinical response and clinical remission as defined by the partial Mayo score. Now, endoscopic outcomes, mainly mucosal healing for both diseases, if they're combined together, you can see combined mucosal healing at week 22 reported in 47.7% in the subcutaneous arm and 40.6% in the IV arm. However, this is not statistically significant in terms of the difference. Same thing at week 54. There is no statistically significant difference between the both arms. So here you can obviously make the assumption or the conclusion that both formulations lead to the same effect on mucosal healing. If we break it down by disease and time point, you can see here on the left you have mucosal healing for both CD and EC, and on the right side you see it only, in the bottom you see it only for Crohn's disease. You can see the difference between the two arms. On the right side, you can see for ulcerative colitis, again, the difference, both statistically non-significant, similar to the pooled data. What about quality of life? You can see the overlapping curves for both arms in terms of short inflammatory bowel disease questionnaire scores for both IV and subcutaneous formulations. And this is up to week 30 of the study. And this represents or reflects consistent improvement in this measurement. Immunogenicity is a very important parameter to be measured in these types of studies. The proportion of anti-drug antibody positive patients were not statistically different between both arms all the way through week 54. So that was for the EU registration studies in IBD. Now for the US regulatory trials, I'll be talking about the Liberty program. So we have Liberty Crohn's disease and Liberty ulcerative colitis. So this is a randomized, placebo-controlled, double-blind, multi-center phase 3 study to evaluate the efficacy and safety of CTP13 sub-Q in moderate to severely active Crohn's disease. So this is the Liberty program. You can see we have a screening phase, then we have IV loading, 3 doses, 0 to 6 at 5 milligram per kg, and then randomized patients in a 2-to-1 fashion based on response to either CTP13, 120 pre-filled syringe injections every 2 weeks, or placebo subcutaneous every other week in the same phase. Now, patients who had lost response at some point are allowed to have an escalated dose of 2 injections, which is 240 milligram of subcut infliximab. And then you have obviously an extension phase or an open label phase following 54 weeks of treatment. When you look at the demographics or baseline characteristics, it's really a very balanced distribution between the two groups. There's no real difference in terms of characteristics, except for a slightly higher number of patients previously exposed to biologics in the CTP13 subcut group. This is the co-primary efficacy endpoints. So we have clinical remission and endoscopic response. You can see at week 54 the statistically significant difference between the CTP13 subcut group versus placebo. On the right side, you can see the same observation in terms of endoscopic response. This is another breakdown of these endpoints in terms of percentages. And there's multiple key secondary efficacy endpoints, such as clinical response, clinical remission, according to PROs, endoscopic remission, and steroid-free remission, all in favor of the active drug arm. So we mentioned pharmacokinetics, the C trough in the first study, same observation here. You can see how the subcutaneous formulation receiving group have a steady state level throughout the study. With regards to the IV, or with regards to the placebo group, you can see initially there's an increase following the loading dose of induction, and then gradual constant drop until it's undetectable. On the other hand, pharmacodynamics, the effect of the drug on the body, and here measured by its effect on CRP and fecal calprotectin, you can see both biomarkers dropping gradually with the subcutaneous infliximab formulation gradually throughout the 54 weeks of the study. In terms of safety, there isn't really any significant observation or signal apart from injection site irritation or reaction as reported to be higher in the drug receiving arm. So there were no trends in the proportion of clinical remitters or endoscopic responders in relation to the development of anti-drug antibodies or anti-drug antibody titer status was observed in either group. There was no overt impact of anti-drug antibody in either group either. So that's for Crohn's disease. What about the identical program in ulcerative colitis? Very similar design. The only difference is the parameters used to measure efficacy. So same thing. So screening, loading dose for induction, doses for induction, maintenance, and then open label study, with the ability to escalate the dose in patients who had lost response. Again, there's no significant difference between the two groups, and these are the primary outcome of and secondary outcomes of the study. So all in favor of the drug receiving arm compared to placebo, with statistically significant p-values across the board. Here's a breakdown with percentages of all primary and secondary outcomes previously viewed in the prior slide. Same thing for pharmacokinetics, almost an identical figure illustrating the same finding. And the same thing you'll see here in terms of pharmacodynamics with regards to biomarker response to treatment. Safety is not different compared to those reported in Crohn's disease. Again, you have a slightly higher injection site reaction report, but nothing too dramatic. So for adverse events for both programs, there is no statistically significant difference detected in terms of TEAEs and SIRs. A significantly lower incidence of infection was detected with monotherapy compared to combination therapy with immunosuppressant, something that is consistently reported with previous similar studies. Immunogenicity, as I mentioned, is very important. A statistically lower rate of anti-drug antibody positive conversion up to week 54 was detected in those receiving combination therapy. What about long-term outcomes in both diseases? So we have 2-year efficacy data for both UC and Crohn's, and compared to the week 54 efficacy results of patients treated in the extension phase in the CTP13 subcutaneous arm were generally maintained all the way up to week 102. So you can see the consistent figures in green and blue are almost identical. Clinical remission response, as you can see here, are very stable, and the trend is almost plateaued in both measurements of clinical remission and response, going all the way through to week 102. In terms of drug persistence, you can see that about 80% of patients receiving CTP13 were still on the drug after a year, and a slightly lower percentage were still on the drug after 102 weeks of treatment for Crohn's disease. For ulcerative colitis, the efficacy data looks very similar. You can see here that about 60% of patients remained in clinical remission after 102 weeks of follow-up. And similar to that, you can see all the figures very closely resembling each other between week 54 and week 102. This is the mean partial Mayo score observed from the beginning of the study all the way to week 102. And again, you can see a plateau around the red line. Persistence, again, you have about 80% of patients still on the drug after 54 weeks of treatment, and maybe a slightly lower figure, about 72% on the drug after 102 weeks of treatment, indicating high drug persistence. As I mentioned, part of the trial design, there was an escalation protocol for both trials for Crohn's disease and UC. So just a reminder, you can see here following induction, re-randomization, patients were allowed to go from 120 milligram every 2 weeks to 2 injections every 2 weeks in cases of loss of response. This is the dose escalation results. So efficacy in dose escalated Crohn's disease patients were quite high. So about 54% of patients were reported to have clinical remission. About 2/3 had clinical response. About 1/3 had steroid-free remission. And the remaining outcomes were also reported in the figure. For ulcerative colitis, clinical remission is a bit lower than that reported in Crohn's disease. Similarly, clinical response is close to 50% as opposed to 2/3 in Crohn's disease. Here you can see mean change in disease activity scores for both Crohn's disease and UC. You can see the change from the first week of dose escalation to week 54 and how there's a decline, a statistically significant decline from those time points for all measurements in both diseases, except for actually SES-CD, the endoscopic score, which is statistically insignificant. Now, when you look at endoscopic outcomes, so here we have the outcomes for both diseases, and this is broken down. We'll start with Crohn's disease here, sorry. So it's broken down according to disease segment, disease duration, and also scores of each segment. So endoscopic baseline characteristics were generally comparable between the arms. Baseline ELA involvement was reported in about 45.5% of patients across both arms, and you can see these scores compatible according to different segments. So here are the results, the endoscopic outcomes. So mucosal healing at weeks 22 and 54. So across ileocolonic segments, endoscopic complete mucosal healing and partial mucosal healings rates were higher with CTP13 compared to placebo at both weeks 22 and 54. In the CTP13 sub-Q arm, endoscopic mucosal healing was achieved across ileocolonic segments as early as week 22 in more than, or at least 69% of patients, and was well maintained in at least 62% of patients at week 54. Again, here are the endoscopic scores displayed according to each colonic segment and the terminal ileum. So here we have week 54 mucosal healing by the mucosal healing observed at week 22. And you can see that a terminal ileal SES-CD score of 0 was detected in 74% of patients at week 22 and 71.9% of patients at week 54. In patients with active terminal ileal disease at week 0, mucosal healing rates were higher at week 54 in patients who achieved complete mucosal healing at week 22 than in patients who had remaining active disease at week 22, indicating association between early mucosal healing and long-term outcomes. Now, this is a summary of mucosal healing rates from other clinical trials, and you can see in comparison the Liberty program endoscopic response rates are among the highest in comparison to most of these trials. Of course, these trials are different design, different times, and it's very difficult to compare apples and oranges, but I guess we can extrapolate a little bit when we look at these figures. Similarly, in ulcerative colitis, same thing. You can see the Liberty UC in comparison to other studies of other drugs. This is a recently published network meta-analysis to evaluate the comparative efficacy of advanced therapies as the first line for maintenance of remission in adult patients with moderate to severe Crohn's disease. And you can see subcutaneous infliximab, 120 milligrams every 2 weeks, scored amongst the highest when compared to placebo in terms of A, clinical remission on the left, and B, endoscopic response on the right. So in conclusion, subcutaneous use of infliximab has been firmly established. It's been newly approved as a drug of choice in the US and also here in the Kingdom. There's high rates of clinical endoscopic measures of efficacy. Pharmacokinetic equivalent study in Europe has been published. Broad real-world experience has been reported in Europe. Early and late switching from IV infliximab is beneficial. There's a large level of use in Europe, and subcutaneous infliximab provides a solid basis for first-line use in both Crohn's disease and ulcerative colitis. Thank you very much.
Thank you, Mahmoud, for this nice presentations. Just maybe one quick question. What do you do in your practice if the patient using infliximab other than Remsima? And you want, if you have a patient who's on infliximab other than Remsima IV, and you want to shift him to sub-Q, do you do anything different, or you just shift immediately?
Yeah, I mean, there's a lot of literature that supports the switch with no issue. There's some exceptions to the rule, but generally speaking, if a patient received IV using, for example, Remicade, it's perfectly fine to switch them to subcutaneous Remsima with no concerns about immunogenicity or anything like that.
Okay. Prof. Gary?
In the Liberty studies that you've just shown on both sides, was the escalation of the dose allowed based on clinical biochemical response, or was that in conjunction with measuring the drug level and the antibodies?
No, just clinical loss of response. So any evidence that the patient is clinically active was a justification for escalation.
So the two very important, I think, points that I would like to know, and maybe the audience here, in the difference between the two. Number one, the trough level, is there any difference? And obviously you said probably there isn't. And the formation of antibodies, whether there's any difference between the two routes.
Yeah, so there was no difference between the two groups with that regard. Actually, it's well known that the trough level is more stable with subcutaneous formulation, and that's one of the advantages that theoretically leads to a decreased risk of developing antibodies with time. And that's one of the reasons you could argue that the subcutaneous formulation could be given as monotherapy rather than combined with an immunosuppression. It depends on the patient. So if there are complicated history, previous failures, I'll probably keep them on combination therapy. But if it's first line, you could argue that you can just discontinue the Imuran after 6 months or so.
Okay. Hamad?
Mahmoud, excellent talk. Again, it's when do you escalate to weekly? Sub-Q weekly. Suppose you have low drug level or you have antibodies? Do you go for weekly injection? And do you go escalate to 240 or you 120 every week? This is my first question. The second question, now with it is a little bit better, the subcutaneous, regarding the trough level, the efficacy, the healing. Why not to shift all IV to subcutaneous? If there is any indication for you to keep patient on IV, number one, and for fistulizing Crohn's, you will give 240, right?
For the escalation protocols, giving 2 injections, which is 240 every 2 weeks. It's not going to weekly. And that would be based on evidence of loss of response, i.e., without the development of antibodies. So if you have antibodies, you're sensitized, there's no point doing that. Now, with regards to, switching patients, there's a lot. No, every 2 weeks. 2 injections every 2 weeks, yeah. So the point about switching from IVs to subcutaneous, so in clinical practice, there's been a lot of studies first that identified predictors of poor outcome in terms of switching from IV to subcut, and the strongest predictor was those who have severe perianal disease. So maybe those are the type of patients that I would argue maybe keep them on what they're getting. They probably need to be on IV along with an immunosuppressant. So in my clinical practice, patients who are stable, in remission, doing well, I've developed the practice of switching them to subcutaneous formulation. I've been doing that in the past few months, and the reason is it saves us admissions to the daycare and a lot of nuisance associated with giving IV medications. And my experience personally so far has been very positive.
Dr. Badr Bharti. Yeah, there's a question there.
Hi, Prof. I've got a question. Do you think we've got enough data now to know what a therapeutic drug level? We've been using this for 2-3 years now, and to start with, we saw these sky-high levels, and we were very happy. We knew that it wasn't equivalent to the trough levels at Q8, but with Liberty now, there would seem that there's probably enough for what represents a therapeutic level, and what we often see is that just like the old-fashioned infliximab, levels can fall with time, and you can recapture. We've been using immunomodulators, even though you can use without, you can put it on, and very low levels of antibodies will disappear, you'll boost levels up again. Do you think we've got a feel for that yet?
Not yet. I mean, I haven't really seen patients in these different scenarios. Well, I had to, measure TDM and be able to decide if this is a drug that behaves differently than what I'm used to, i.e. Remicade. However, it's only been available in the kingdom for a short period of time. If you guys have had it for the past 2 or 3 years, I'm sure that you've had more experience looking at this specific. The second thing is TDM use in the kingdom is a bit sparse because of availability and insurance coverage. So it's usually paid out of pocket. So we don't really have that much data to be able to answer that particular question, I believe.
I mean, our experience has been that it's just like giving adalimumab. So if you were used to looking at levels with adalimumab, and in my head, that's, traditional dosing is 40 every other week. This is 120 every other week. Well, if I accept an adalimumab level of, say, greater than 7, maybe I'd want 3 times that. It's not quite the same, but often we'd see levels above 20. And so you can then, but we were slightly making it up. The thing that was apparent was as antibodies formed, if you were monitoring quite closely, you can overcome them with immunomodulators, just like you can with the other anti-TNFs.
Prof. Yusuf was asking about injection skin reactions. I mean, in Liberty program, it's less than 5%. I think we need to, and that might be different from one population to another. So again, we need to really develop our own experience here in the kingdom. We know that's really the same figure or less or more. Who knows? I don't know, Gareth, is that the same, about less than 5% or?
Yeah, we see, again, similar, actually pretty low levels of skin reactions. The most typical one is just itching and sort of like a wheal, and often goes away with antihistamine, sometimes pre-dosing on the day with an antihistamine on the day that you take it, if it's consistent. And using a steroid cream, often put a bit of steroid on first, leave it for a couple of hours, then inject into that area where you've put the cream, and then it doesn't happen.
Okay.
Our nurses are fantastic at getting patients to sort of manage through those.
We have time for questions, Dr. Badr Bouardi.
Yeah, great talk, Mahmoud. So you talked about some predictors of potential relapse after switching. Some of the switching studies suggest that if patients are on 10 mg per kg every 4 weeks IV, they're at high likelihood of switching, high likelihood of flare after you switch them to sub-Q. So are these patients in your practice that you would discourage switching, or are you going to switch them to dose escalated 240 every 2 weeks?
I would discourage switching. Those are the type of patients you really don't want to, modify their treatment regimen. Plus, there's no literature that directly makes that comparison in a long study. So these are all observational, type of conclusions. So yeah, I would definitely discourage switching in a patient who has failed multiple biologics, who has severe perianal disease, severe penetrating disease, or is only successfully maintained on that high of a dose and that very short interval. So yeah, I would definitely do that.
Thank you, Prof. Mahmoud, again. Thank you all for staying late with us today. I'll invite to the stage Prof. Majid Al-Madi. Prof. Majid, our president of the STA. So there will be a ceremony and from Al-Hikmah.
بسم الله الرحمن الرحيم. أولا أود أشكركم جدا على الحضور اليوم، ما شاء الله تبارك الله، حقيقة فاق التوقعات، ومكوثكم إلى هذا الوقت المتأخر من اليوم برضو أيضا يعني مدعاة لسرورنا وشكرنا. أعرف البرنامج تبقى في جزء بسيط إن شاء الله المساء الليلة. الليلة يعني من وقع اتفاقية مذكرة تفاهم إطارية مع الحكمة. أعتقد أنها تأتي تتويج لمسيرة طويلة من التعاون بين الطرفين. حقيقة الجمعية خلال السنوات الماضية ولله الحمد بأعضائها بمجلس إدارتها مشوا بمراحل كبيرة على الخطى المؤسسين الأولين، وعندها إرث كبير من ناحية كثقافة مجتمع أطباء جهاز هضمي وتناغم بينهم كبير. في نفس الوقت المخرجات خلال السنوات الأخيرة ما شاء الله تبارك الله حقيقة لا كأطباء في المستوى أو في العدد أو في الانتشار في أجزاء المملكة. يعني ما شاء الله عندنا اليوم مقابلة عدد من المتدربين الآن في الحدود الشمالية، في الغربية، في الجنوب. مستوى الخدمات المقدم على مستوى الجهاز الهضمي جدا رائع. مستوى الوعي للمرضى كبير في نفس المجال، والارتقاء بمستوى الخدمات الصحية حقيقة مشرف في المملكة والحمد لله. جزء منها أيضا حقيقة التناغم خلال السنوات اللي فاتت بين الجمعيات في الخليج كان أصبح أكبر وأكبر. أعتقد المجتمع الآن أطباء الجهاز الهضمي على مستوى الخليج في تناغم مرة كبير من ناحية البرامج المشتركة، تنسيق المؤتمرات، التعاون بين الجهات، وهذه كلها يعني تحمد للزملاء في الدول الخليجية وللزملاء أيضا في الانترست جروبس، المجموعات المتخصصة في الجمعية السعودية. الحكمة جزء من سلسلة كبيرة من القطاعات الدوائية اللي تعاملنا معها في الفترة الأخيرة، ونأمل يعني خلال السنة الماضية ما شاء الله تبارك الله كان في عدد من البرامج والنشاطات المشتركة في ناحية توعية المرضى والمجتمع والمرضى والممارسين الصحيين كأطباء وكتمريض. كل هذه البرامج حقيقة كان لها أثرها الملموس، وعدد يعني المستفيدين منها كان جدا كبير خلال السنة الماضية، وارتئينا أن تكون يعني الاتفاقية أكثر إطارية وأكثر شمولية، وإن شاء الله نبني عليها السنوات القادمة. تفضل الله يحفظك. إذا عندك شيء تبغى تضيفه؟ هذا انجلش فيرجن لازم. Okay. Okay, so I'll just give a small spiel of what we just said. So over the years, the Saudi Gastroenterology Association has been growing in its reach and effect over different geographical regions and on different healthcare provision sectors. The SGA has been involved in the upskilling of healthcare practitioners, whether we're talking about the scale of the nursing, technicians, healthcare physicians. We've participated as individuals and as an organization in multiple sectors in the healthcare delivery system, whether it be in the health holding company, the Saudi Commission for Health Specialties. We've engaged with the Saudi Health Council. All these organizations have been a venue for our collaboration with the SGA. Also, interacting with the industry has been a major role in the expansion of our activities and effect. Over the last year, we had a few programs with Al-Hikmah. Some of them were targeted to nurses, some of them targeted to healthcare professionals, physicians, gastroenterologists. Part of it was funding even the IBIS course, this conference. And we thought that we would crown this with a memorandum of understanding with Al-Hikmah and hopefully have clear targets for each and every year and to achieve them and work on them together. You're good? So we thank all our sponsors in addition to Hikmah, and we thank you for staying at this late time. And I think Nahla has a program after this also for women in IBD-GI. So thank you very much.
السلام عليكم ورحمة الله وبركاته. نتشرف بتوقيع مذكرة التفاهم اليوم بين شركة أدوية الحكمة، الشركة اللي نبعت وتجذرت بالمنطقة العربية قبل ما تكون مالتي ناشونال كومباني. صحيح اليوم الحكمة تعتبر ثاني أكبر مورد للإنجكتبل بزنس بأمريكا بالولايات المتحدة الأمريكية، ولكن اللي بيجعل الحكمة توزيع مبيعاتها هو المختلف عن يمكن other multinational companies، الكونتريبيوشن أو المساهمة بمنطقة الشرق الأوسط هي الأكبر، تعتبر حوالي 34% مقارنة مع أقل من 2% مع الشركات الأخرى. وبالتالي احنا ننظر إلى منطقة الشرق الأوسط وشمال أفريقيا والمنطقة البلاد العربية منطقة أساسية بالاستثمار ودعم المشاريع العلمية، وبالتالي مثل هيك مبادرات نتشرف بيكون وجودنا معها كشركة أدوية الحكمة، وخصوصا عند الحديث عن جمعية مثل الجمعية السعودية لأمراض الجهاز الهضمي اللي فيها قامات علمية مميزة جدا طوال الفترات الماضية، كانت يعني رول موديل لجمعيات أخرى في الوطن العربي، سواء بالمخرجات البحثية أو كمخرجات علمية ورفع كفاءات القطاع الصحي في المملكة العربية السعودية، لأن نفتخر ونتشرف اليوم نكون جزء من هذا البروجرام أو هذا البرنامج، ونكون شركاء في إن شاء الله هذا النجاح، وخصوصا الذي يستهدف مرضى التهاب القولون التقرحي، اللي ممكن الإديوكيشن أو التعليم يفرق بين حياة المريض ما بين أنه يكون شخص منتج وأقل اعتمادية على العائلة، أو لا سمح الله بالجهة الثانية يكون شخص بحاجة لدعم بشكل مباشر. فأخيرا بشكر الجمعية مرة أخرى، بشكر الدكتور ماجد الدكتور فيصل على إعطائنا هذا الفرصة، وإن شاء الله مستمرين في الدعم لاستهداف التعليم للمرضى وللمقدمين الرعاية الصحية، وهذا التزام منا مستمر إن شاء الله بالثلاث سنين القادمة نستمر على نفس المستوى وأعلى إن شاء الله. شكرا مرة ثانية، يعطيكم العافية. It's an honor.